Good morning. Welcome to the second day of the 6th Annual Congress of the SLTRIMS. And this morning, we start an exciting plenary on autoimmune neurology. We have lined up two world-renowned speakers to share their expertise with us. So we will start off with a very interesting topic, cases in autoimmune neurology. And it's my great pleasure to invite Professor Eoin Flannagan, who needs no introduction to the Sri Lankan audience. But Professor Flannagan is the Professor of Neurology, Mayo Clinic, Rochester, Minnesota. So let me invite Professor Eoin Flannagan to deliver his talk.
Thank you so much. Hopefully you can hear me okay. It's a real pleasure to be with you again today. I think it's actually still the same day for me as when I presented early in the morning last night. But a real pleasure to talk to you today on an exciting topic of cases in autoimmune neurology. These are my disclosures here, not too relevant to this talk, which will focus mostly on diagnosis. So we'll try and identify some of the clinical and radiological features in patients with autoimmune neurologic disorders, and then we'll talk about some advances in neuroimmunology, diagnostics, and treatment. For the first case I'm going to present, I'll title this one Attacks of Ataxia. So this was a 24-year-old Caucasian man who had presented with subacute vertigo for a few weeks, and then would develop these episodes where he would have slurred speech and right hand incoordination. His job was actually, he would work during his job and he would have to give short presentations for 20 to 30 minutes about different products. And this was interfering with his ability to give those presentations. And these would occur every hour, sometimes could be triggered from going from the standing to seated position. His past medical history otherwise included attention deficit hyperactivity disorder, history of infectious mononucleosis, postural orthostatic tachycardia syndrome, and celiac disease. And there was nothing too relevant in his social history, family history, and he was not taking any medications. So I'll show a video here, and hopefully you'll be able to see this here. Okay. So this is one of the episodes.
And then we'll have you stand up. Okay. And then we'll just kind of see how you feel.
Okay.
Oh.
Feel fine.
Okay. Do a couple of these. We'll just see.
Okay, so I'm having an episode right now
Okay.
where
Okay, why don't you read a couple of lines there?
when the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors, and it went away. These take the shape of a long round arc.
Okay. Now one more time, why don't you go back and forth with my finger? Okay.
So highlighting these kind of short-lived episodes of ataxic dysarthria and appendicular ataxia on the right side here that he had. He had a workup before he had been sent to me. Actually performed initially a virtual consultation. He had a white blood cell count of 1, and his CSF oligoclonal bands were positive, and he had serum and CSF autoimmune encephalopathy panel that were essentially normal. And actually he had genetic testing for some of the genetic conditions associated with episodic ataxia, and all of these came back negative. His MRI brain, initially this lesion was actually missed, but on re-review, there was evidence of a T2 hyperintensity here within the cerebellum on the right side, which would localize to symptoms. And then we could see here a ring of enhancement around the lesion. And in follow-up, this lesion persisted over time. And then he was also noticed to have a spinal cord lesion in the cervical cord. And as I mentioned earlier, he had CSF oligoclonal bands. So this was consistent with paroxysmal ataxia and dysarthria in the setting of multiple sclerosis. And he initially had been treated with acetazolamide, actually on the suspicion that this might have been one of the channelopathies and the genetic ataxias. But carbamazepine is often used first line in this, and even low-dose carbamazepine will often work. But acetazolamide is another medication that can actually help. This was first described actually by a neurologist from Ireland. So his name is Harry Lee Parker, and actually he was originally from Ireland, and then he had went to the Mayo Clinic. He'd worked there for many years. Then he went back to Ireland, and then he went back again to the Mayo Clinic. So this is him here. He was from Limerick, which is one of the counties in the west of Ireland. I'm actually from Dublin myself in Ireland. And some of our neurologists, Dr. Chris Bayes at Mayo Clinic, has written a very nice article on the history of neurology about Harry Lee Parker. He's quite an interesting historical character who was one of the early neurologists at the Mayo Clinic. And so paroxysmal episodes in MS do occur. We'll recognize many of these. So Lermite's phenomenon will be one example where it's triggered with neck flexion. Trigeminal neuralgia is another well-recognized phenomenon that we can see, but some of the others are less well-recognized. Tonic spasms, again, we can also see this even more commonly with neuromyelitis optic spectrum disorder, where patients will get flexion spasms of their arms or legs. But you can also have paresthesias, you can have vertigo, diplopia occurring. And it's thought that this is related to aphaptic transmission from the area of demyelination and then transmission to unmyelinated nerve fibers. The patient had been placed on B-cell depleting treatment with ocrelizumab and has been stable ever since, and had no subsequent recurrence of his paroxysmal dysarthria and ataxia. Just one neural autoantibody I'll mention is Caspr2 antibodies can also present with paroxysmal dysarthria and ataxia, but he tested negative for those. So anyway, an interesting case of paroxysmal events that turned out to be multiple sclerosis. So the second case I'm going to highlight, I'm just going to go through a few rapid fire cases here just to highlight some autoimmune neurology. Some of these are classic cases, but I think they highlight some interesting points. So this was a 28-year-old female. These are all patients that I saw. She presented with subacute psychosis, memory loss, seizures, and catatonia in the postpartum setting. She was initially diagnosed with postpartum psychosis, but subsequently the diagnosis became more apparent. Her MRI was completely normal, but she had evidence of CSF pleocytosis with 20 white blood cells, and her EEG revealed this extreme delta brush pattern with superimposed beta on top of delta slowing. So superimposed fast activity on top of delta slowing. That's pretty typical of this diagnosis. And she had antibodies sent to our neuroimmunology lab, and we saw staining in the CSF that lit up very brightly in the hippocampus and in the granular layer of the cerebellum and also in the cortex. And then also there was a cell-based assay for NMDA receptor antibodies that came back positive. You can see the cells with the NMDA receptor transfected on the surface here, and then the cells in the background without any NMDA receptor. And the diagnosis here was anti-NMDA receptor encephalitis. She was treated with IV steroids. She had actually received IVIG and subsequently received plasma exchange and also rituximab treatment. The patient was hospitalized for 2 months, had a slow improvement to normal over the next 10 months, but did get back almost or pretty much completely to normal afterwards. So you can see kind of a long progression of symptoms. Despite aggressive treatment, it can take some time for this to improve. And this is an antibody, we'll talk about this, an antibody to a cell surface target, being an antibody to a receptor on the cell surface. So we think that those antibodies can be potentially pathogenic. So here's another case. This patient was also having spells, kind of like the first patient I presented. This patient was having multiple spells every day of jerking of his arms and of his face, where he would drop things from his hands. So here's an example of one of the episodes. And he had no response, to levetiracetam treatment. These were happening up to 9 times a day.
All right, now stand up quick. Oh, good God. That happened to you? Oh, you just have one? No. What do you mean, did I just have one? Did you just have a spell? Did I? Yes. Okay. How did it feel?
And I can just go back to the right side of the
Oh,
face, you'll
just
see a
that one?
twitch and a twitch of the arm. That's very classic for these conditions. Again, in this situation, the MRI was normal and the CSF was completely normal. So you can imagine how the diagnosis might be difficult to make here in the setting of a normal MRI and a normal CSF, but this is actually not that uncommon with this condition. And again, he was tested for LGI1 antibodies in serum, and these were positive, and these were fatiobrachial dystonic seizures, and the diagnosis was anti-LGI1 encephalitis. These fatiobrachial dystonic seizures are pretty much pathognomonic for LGI1 antibody encephalitis. This patient would not fulfill the diagnostic criteria. He didn't have any memory loss, so would not fulfill 2016 diagnostic criteria, as he just had these spells of seizures. But with that criteria, you need to have subacute memory loss or altered mental status. So just be careful that there are some patients that may not meet the autoimmune encephalitis diagnostic criteria, but still have an autoimmune neurological condition. The interesting thing with him and with these conditions is he was treated with IV methylprednisolone 1 gram a day for 5 days and an oral taper of steroids for many months. But he actually, his symptoms resolved within, I would say, about 2 weeks. So he was completely back to normal within 2 weeks, compared to the prior patient where it took 10 to 12 months to get back to normal. These mostly resolved within 3 days and did not recur. So these two cases that I just presented, the NMDA receptors and the LGI1, are antibodies to cell surface or synaptic targets. So these antibodies, we think, have the potential and have often been proven to be potentially pathogenic. So they can bind to the receptor, and that can result in endocytosis and degradation of the receptor. The binding of the antibody to the receptor can lead to loss or alteration of function. Binding to the receptor can recruit in other immune cells, so you get antibody-dependent cellular cytotoxicity, or antibody binding can trigger complement activation, particularly, for example, with aquaporin 4 antibodies. These antibodies are associated with a lower risk of cancer than some of the antibodies to intracellular targets that we'll talk about, and they tend to respond well to treatment, particularly with antibody targeted treatment. So that might be removing all your antibodies with plasma exchange, neutralizing all the antibodies with IVIG, or preventing their production with treatments like rituximab. And they overall have a good prognosis. So these are patients where if they do have an antibody to these targets, you really want to treat them aggressively, because these patients, even though they're very severely ill, can really recover close back to normal. So the next case is a different case. This was a 41-year-old man who presented with subacute ataxia. And after about 6 weeks, his walk was, he had previously been walking normally, but then his walk was like I will show here.
And if you want to hang onto her hand, perfect. Now just go your own pace. And please tell us if you start to get tired. I think I can go like.
You can see he's wide-based, he's very unsteady, requiring the assist of 2 to walk. And then he also had an ataxic dysarthria.
Which did know of my grandfather. Well, he is merely 93 years old. Yeah.
So this was a pretty rapid presentation of ataxia. So you would be suspicious for a potential autoimmune cause. He had a CSF performed as part of this and had elevated white blood cell counts, 71 white blood cells, and positive oligoclonal bands. He had evidence of leptomeningeal enhancement on his in his cerebellum. And on his antibody testing, we didn't actually know what the antibody target was at the time, but we had seen this in our lab. This was seen by a colleague of mine at Mayo Clinic and then sent to me as an autoimmune subspecialty consultation. And in the laboratory, we saw this sparkles pattern. And we had seen this pattern in 10 or so other patients, and all of those patients had had seminoma. So we knew that this was associated with seminoma, and many of those patients had either a rhombencephalitis or a paraneoplastic cerebellar degeneration type phenotype. We did a PET scan, and there was some slight uptake within the para-aortic nodes. We know that this is where testicular tumors can metastasize to. His testicular ultrasound just showed some testicular microlithiasis that can sometimes suggest a burnt out tumor, but we biopsied this and it was consistent with metastatic seminoma. So he was diagnosed with anti-Kelch-11. This was later proven in collaboration with a group at UCSF, Dr. Sean Piddock, Div Dubey and colleagues, along with Michael Wilson's team at UCSF, discovered the target antigen to be Kelch-like protein 11. And this was published in the New England Journal of Medicine. And this patient was treated with chemotherapy with bleomycin, etoposide, and cisplatin, and his cancer completely resolved. He also received treatments of IV steroids, prolonged oral steroids, plasma exchange, rituximab, and cyclophosphamide. And really, he had no response neurologically to any of this treatment, and he remains quite similar to how he was after the first couple of months of his presentation. And he's also developed cerebellar atrophy over time. So this is classic for an antibody to an intracellular target. So this is nuclear or cytoplasmic targets. In these situations, we think that these are driven mostly by cytotoxic T lymphocytes, and that the antibody cannot directly attach to its target antigen due to the cell membrane preventing that, but that these peptides are upregulated on MHC class 1 and they target the cell for destruction. So these are quite destructive process with, we think, driven by cytotoxic T lymphocytes. So these have a higher association with cancer. So many of these antibodies, like the Purkinje cell autoantibody type 1 or anti-Yo antibody, the predictive positive predictive value for cancer is 90 to 100% in some of these cases. And they tend to respond poorly to treatment, like we showed here, and overall have a poor prognosis. So I think this is a real area of need for us in the field of paraneoplastic disease. These classical paraneoplastic diseases, really, we despite all the advances we've made, we really don't make much of a difference in terms of their treatment. Okay, so I'll move on. I just wanted to highlight a few of those quick fire cases, highlighting the difference between the antibodies to the cell surface, where we can predict a good prognosis, and the antibodies to the intracellular targets, where the prognosis is poor. So the next case I'm going to title White Overnight. So this was a 34-year-old male, Caucasian, who had a history of diabetes and developed diabetic ketoacidosis, but his hemoglobin A1C was not severely bad. And while he was in the hospital, he was noted to have very low blood pressures. His blood pressure was 50/25. He had difficulty transitioning from dark to light. He developed early satiety and also had a neurogenic bladder and orthostasis with up to 2 syncopal episodes every day. So really very prominent dysautonomia developing subacutely here in this patient. Again, his history, he had a history of type 1 diabetes on an insulin pump. He also had ulcerative colitis and had a previous colectomy. He had a history of hypothyroidism. He also had a history of cerebellitis that was unsure of the exact cause, but thought to be possibly autoimmune. So a whole cluster of autoimmune disorders here. In his hospitalization, he'd been placed on fludrocortisone and midodrine to help with his orthostatic hypotension, and he was on some other medications as part of his autoimmune comorbidities. When we saw him, his supine blood pressure was 145/102, and that dropped to 71/42, and he was symptomatic on standing, so definite orthostatic hypotension. He had some mild appendicular and trunculate tachycardia related to his prior cerebellitis, and the rest of his sensory testing was normal. His pupillary responses, he didn't really have much pupillary responses consistent with his dysautonomia, as you can see here. He underwent autonomic testing. We have something called an autonomic reflex screen here at Mayo Clinic, where we can measure cardiovagal, cardiovascular, adrenergic, and pseudomotor function. And he had abnormalities in all of those, and had his findings were consistent with the severe autonomic neuropathy. We also have a sweat test at Mayo Clinic. That's another way we measure the autonomic function. So we'll put patients into kind of a sauna, and then we'll put powder all over them, and we'll see if they can sweat. Patients that do not like this test, it's kind of a little bit uncomfortable. But what you'll see here is that the normal is complete purple color, and you can see that he has a lack of sweating through the forehead and throughout much of his body. He was tested for the ganglionic acetylcholine receptor antibody, and he had a very high positive at 1.45 nanomoles per liter. So he had what we thought was an autoimmune autonomic neuropathy, or autonomic ganglionopathy associated with the ganglionic acetylcholine receptor antibodies, different from the muscle acetylcholine receptor antibodies that we know as the target of myasthenia gravis. And this was a study led by Dr. Lennon and also in collaboration with Steve Bernino, where they showed that these antibodies to the ganglionic acetylcholine receptor antibodies associate with these autoimmune autonomic neuropathies. And they were able to show immunization with the neuronal nicotinic acetylcholine receptor would induce neurological dysautonomia in rabbits. So here you'll see GI dysfunction, and these rabbits will get neurogenic bladder and similar symptoms. So proving that the antibodies are pathogenic. There was an interesting twist in this case. I'll show in the next slide. He was initially treated with IVIG, 0.4 grams per kilogram, for a 12-week course, and he was placed on oral mycophenolate mofetil. Also, we consulted with autonomic neurology, and we placed them on pyridostigmine to increase the amount of acetylcholine in those ganglia. He was also placed on salt sticks, and then we had him on Job stockings and an abdominal binder, and some other counter pressure maneuvers to help him reduce his orthostatic hypotension. But something happened in the few days after he received IVIG. So I don't know if anyone can look at the difference between these two pictures, but this is the same person. Here you can see he had this kind of black and white peppered hair, and his beard here you can see was a mixture of black and white, his eyebrows. And after he received his course of first dose of IVIG, all of his black hair fell out. So he lost all the black hair from his head, from his eyebrows, and also from his beard here. Now, he felt that the IVIG was so beneficial to him that actually he was not too bothered by losing the hair and really thought that he wanted to continue on the IVIG. But we were intrigued by this, and we're wondering what might have happened. But our hypothesis is that this was a diffuse alopecia areata. A selective dark hair loss is thought to be related to white hair lacking the follicular melanocytes that are thought to be the immune target in alopecia areata. And we hypothesized, I suppose, that the IVIG, that somebody who donated IVIG maybe had alopecia areata and had antibodies to follicular melanocytes that then bound to his dark hair and let it to fall out. And indeed, alopecia after immunoglobulin infusions has been reported back in The Lancet in 1987. There are some rare reports. We know that IVIG also can have other complications like aseptic meningitis, both venous and arterial thrombosis. You can get an erythroderma type rash. You can get renal impairment from the sucrose component, and you can have, if you have IgA deficiency, you can have an allergic reaction. But this was a rare kind of idiosyncratic reaction to causing diffuse alopecia areata. Historically, this has also been reported in the past. It's been labeled as Marie Antoinette syndrome. Queen Marie Antoinette from France, when she was told that she was going to go to the guillotine, apparently that night her hair went from a mixture of dark and gray to completely gray hair. So this has been reported before. Okay, I'm just trying to see how we're doing for time. I think we can go through one quick more case. So this case is called a one-sided story. This was a 34-year-old female who presented with a generalized tonic-clonic seizure and had reported 1 week of headache, photophobia, and focal seizures with right-sided twitching. She also had encephalopathy as well. And there was, on examination, there was a mild right hemiparesis, and there was evidence of bilateral papilledema. And this was the MRI. There was evidence of T2 hyperintensity within the cortex that we can see here. And there was also evidence of enhancement within the meninges and a little bit of cortical enhancement that we can see here. And the CSF was inflammatory with 387 white blood cells, and oligoclonal bands were negative. And the CSF opening pressure was, this should be millimeters, 400 millimeters of water or 40 centimeters of water. And she was placed on levetiracetam, was given empiric antibiotics because there was a suspicion that this was an infectious meningitis. But all of these other investigations came back negative, and a brain biopsy was actually performed because it was thought that this may represent tuberculosis meningoencephalitis. The brain biopsy showed diffuse subcortical white matter, diffuse subpial demyelination. There was evidence of prominent microglial infiltration within the cortex, and there was prominence of CD4 cells, but also some CD20 cells. 1 month later, this patient was tested for MOG antibodies, and they came back highly positive at 1 in 1,000. And OCT, MRI of the cervical and thoracic spine were negative. So if we think about the latest diagnostic criteria, this patient met criteria for the cerebral cortical encephalitis phenotype. They had a clear positive MOG antibody, and there was no better diagnosis. So this was consistent with MOGAD. This was, I know Professor Fujihara is here. This was a really nice initial discovery by Professor Fujihara and his colleagues, where they found this unilateral cortical T2 hyperintensities within the cortex, and also noted some hyperperfusion in these cases. Adrian Budrum subsequently used a term that's described here as flames, which is unilateral cortical flare hyperintense lesions in anti-MOG associated encephalitis with seizures, or flames. I think the cerebral cortical encephalitis is a little bit of a better term. The flames is a little bit long-winded, and not all of the patients have seizures. But he highlighted some of these clinical and radiological features also. We'd looked at this amongst our cohort at Mayo Clinic, and we found it was present in about 6.7%. And these patients would have headache, seizures, encephalopathy, and other focal cortical features like aphasia, hemiparesis, and fever. NMDA receptor antibodies coexist a bit more frequently than we might expect, so that's something to consider. These patients are often misdiagnosed as having vasculitis or stroke or seizures, so it's important to think about this, because if you just have cortical involvement, many people don't think of a demyelinating condition, but the cerebral cortical encephalitis is one condition that can do this. Here's some other MRI examples. You can see unilateral cortical swelling and T2 hyperintensity. It's pretty obvious in this case. And you can see here leptomeningeal and even some cortical enhancement here. Other times it's not quite as obvious here. If you flip through this quickly, you may miss it. But here you can see cortical T2 hyperintensity and some subtle leptomeningeal enhancement. So I think I'm going to stop there, and I'm going to flip to the very end here. I'll just flip through some of the slides just to summarize in the last slide. Sorry to go through this quickly, because we won't have time to get through this last case. So what did we learn about today? Well, we first learned about the patient who had the attacks of ataxia with paroxysmal ataxia and dysarthria, first described by Harry Lee Parker due to a phaptic transmission. We talked about antibodies to cell surface targets with NMDA receptor antibodies taking a long time to recover, but often recovering to normal. We talked about facial-brachial dystonic seizures and how they can rapidly resolve with treatment. We talked about antibodies to cell surface targets where the antibody is potentially pathogenic. And we talked about the patient who had antibodies to intracellular targets that, again, had a metastatic seminoma and had Kelch-like protein 11 antibodies, but didn't respond very well to immunotherapy. And then we talked about our patient who had an autoimmune autonomic neuropathy, who developed an idiosyncratic reaction from IVIG, where all of his black hair fell out. And we talked about how these ganglionic acetylcholine receptors have been shown to be pathogenic, are important to recognize in patients with dysautonomia. So I will stop there. I'll acknowledge all my team at Mayo Clinic. We mentioned all of them yesterday, and I'll open it up for any questions. Thank you very much for your attention.
Thank you, Professor Flannagan. And the session is now open for questions. Manjula.
Thanks, Professor, for that excellent talk. That very interesting case with the autonomic ganglionopathy patient with autoimmune as well receptor antibody positive case. How long you need to continue the immune suppression or immune modulation for those patients?
It's a little bit hard to know. It's quite a rare phenomenon in my experience, but in general, we would often use IVIG and maintenance therapy for at least probably 3 to 5 years, and then maybe reassess and see how the patient is doing. But some of these patients may need it in the longer term. But I think they often benefit a lot from the IVIG because they get hydration in addition to the immune benefits of the IVIG, and many of them need long-standing treatment for the dysautonomia. So you may be able to pull off the immunotherapy after 5 years, but many of them require long-standing treatment for the dysautonomia.
Thank you.
Professor Fujihara.
Owen, thank you very much for the nice talk. And so thank you for mentioning our initial report on cerebral cortical encephalitis. Most of our experience is that those cortical encephalitis are seen as isolated lesions. But when I see the pediatric cases with MOGAD who developed cerebral cortical encephalitis, in some of them, subcortical lesions, relatively big, expand and involve cerebral cortex. In your cases with the cerebral cortical encephalitis, did you see any other brain lesions, or are they just isolated cerebral cortical encephalitis?
It was a bit of a mix. It's a great question, and it's one of my favorite papers and studies that was published in MOG. So it's a really nice one from 2017. Yes, we saw about half of our cases. I think approximately half of them had other lesions. They had cortical encephalitis, but then they had other lesions that kind of had an ADEM, disseminated encephalitis type presentation. So we saw some of those cases, and it can be difficult to see lesions in the cortex, but I suspect on many of the biopsies we often see cortical demyelination in those cases. So it may be that we're missing involvement of the cortex in cases of ADEM, for example. We don't see lesions. Maybe there is cortical involvement because many of those patients have encephalopathy. But I think that the real challenging cases are the ones that get misdiagnosed, are the ones where it's isolated to the cortex. They're the really challenging ones to recognize and support for people.
Okay. And what percentage of your cases with cerebral cortical encephalitis were relapsing?
Yeah, I think it was a high proportion. I can't remember the exact number, but I would say maybe 75 or 80% were relapsing. A lot of them had very high titers of MOG. They were often 1 in 1,000, because we have to be a little bit careful with expanding the spectrum of MOGAD when low titers can be seen, and sometimes peripheral neuropathy or other things reported. But the cerebral cortical encephalitis is a really good example of how you can expand the spectrum, because many of these patients went on to have some of them went on to have recurrent cortical encephalitis. I think it was 3 or 4 cases out of the series that we had that had recurrent episodes of cerebral cortical encephalitis, and then many others went on to have typical optic neuritis episodes or other attacks.
Okay, well, thank you very much.
Thank you.
Professor Flannagan, if I may ask just one quick question about the cortical encephalitis. Now, MOG is said to be targeting the MOG, which is in the white matter. And here we are talking about a pathology in the gray matter. So is the MOG actually pathogenic there, or are we thinking about unidentified antibody associated with MOG? Or how do you explain the targets in the gray matter in cortical encephalitis?
Yeah, it's been a little bit difficult to explain that. There is MOG present in the cortex, but we do know that MOG, for example, in the spinal cord tends to involve the central gray matter and forms this kind of H sign sometimes. We know that the deep gray matter tends to be involved quite frequently in MOGAD cases, and then the cortex, like we can see here. So I don't think we fully understand. Some people like Manna Hofberger is one of the expert pathologists on MOGAD, would say that maybe there's an outside-in type pathogenesis, and that it comes from the outside, targets the cortex, and moves its way in. But I don't think we really know. One thing we've recognized recently is that some patients will have meningitis or meningoencephalitis, and there's no MOG present, as far as I'm aware, in the meninges. Yet patients will have meningeal enhancement. We commonly see that with MOGAD. So I don't know if that's from spillover inflammation. So it's a little bit hard to understand. Like aquaporin 4 tends to follow much better. The lesions tend to follow areas that are aquaporin 4 rich. I don't think it's likely to be a different antibody, because I think just the MOG antibody is so good now, quite reliable in terms of the presentation. So we don't really know what the reason is, or why do some people get recurrent optic neuritis, never have any brain involvement? Other people have multiple brain attacks. Do they have greater MOG expression? I don't think we know, but plenty more to learn, I think. So a great question, and something that's really keeping us up at night in terms of understanding the pathogenesis of the condition.
Thanks a lot, Professor Flannagan. Let us show our appreciation in the usual manner. And we now move on to our second talk.
So from that very interesting array of clinical cases, now we are going to move on to discuss treatment. So it's my absolute pleasure to introduce Professor Divyanshu Dubey, again from Mayo Clinic, Associate Professor of Neurology, and he has played a key role in introducing several antibody biomarkers. So he's going to speak to us virtually. So over to Professor Dubey, who is going to talk to us on evidence-based treatment in autoimmune encephalitis.
Thank you. Thank you for inviting me. Thank you for the kind introduction. It's very hard to follow Dr. Flannagan after his talks, but I'll try my best. My talk is going to be very clinically focused, very sort of reflecting to some extent our practice here at Mayo Clinic, but also sort of discussing briefly sort of some of the evidence that supports some of the treatment regimens that we tend to utilize. Let me see. These are my disclosures. Let me just make sure I minimize the side screen. We'll be talking mostly about treatments, not a lot about some of the novel antibodies, but the objective of this talk would be to review some of the treatment approaches. As I said, we'll touch on paraneoplastic encephalitis as well, but in the first, most of the talk is going to be on autoimmune encephalitis. The way I've divided this talk is into 3 individual cases. To sort of give you an example of some of the patients we especially encounter in our inpatient and outpatient practice. In most of these scenarios, I think the concepts of the treatment approach ends up remaining the same. Oftentimes, immunotherapy is initiated even before the antibody results are back. And in these cases, usually have a clear sign that there's an underlying autoimmune or paraneoplastic process going on. It could be limbic encephalitis, so there are not too many things which can cause bilateral asymmetric medial temporal lobe T2 flare hyperintensities with inflammatory CSFs. And then usually in those scenarios, if the patient has subacute progressive cognitive changes or new onset seizures, usually we are relatively trigger happy and start the patients on immunotherapy, especially when some of the initial infectious results come back. Another example would be a patient presenting with cognitive impairment as well as facial brachial dystonic seizures, which are pathognomic for LGR1 autoimmunity. You don't usually need to wait for antibodies to come back in treating those cases. Some of the other patients presenting with sort of what is called as the probable seronegative autoimmune encephalitis or possible autoimmune encephalitis, oftentimes ruling out some of the infectious etiologies or some of the initial infectious results end up being helpful. And then the antibody test results, and we are lucky to be working at Mayo where we have the lab. Pretty much my office is based in the lab. I can actually easily access some of the test results much before they even released in our electronic medical record system. But for most of the other sort of people working elsewhere, these antibody test results, even if they come back later, actually they are very helpful. They not only can guide subsequent management if the first line therapies are not working, In some cases where you are on the fence whether this is autoimmune encephalitis or not, the antibody test results can help you push forward and give the patient's treatment. And then it probably gives you an idea about the natural history of disease. Is there a high risk of relapse? Do we need to put these patients on steroid-sparing agents, examples being rituximab, mycophenolate, mofetil, cyclophosphamide, and then the cancer search, which ends up being important for some of the high-risk paraneoplastic antibodies. One of the conceptual approaches which was taught to me by Dr. Pittock is this 3M approach, where you try to try for the maximum recovery with a minimum dose of treatment. And then this particular approach will be reflected in each of the cases as we talk through these things. These are some of the therapies which are currently either actively being utilized in clinical practice for management of autoimmune encephalitis, or some of these ones which I've pointed out here, this is a review article which will be coming out very soon, are therapies which are actively being investigated in clinical trials. Examples being bortezomib, which is being sort of in a clinical trial for an MD receptor encephalitis, IL-6 receptor blockers, which are being studied in a CIALO trial for LGI1 and NMD receptor encephalitis, and then FcRn inhibitors, rozumab, which is being investigated for LGI1. The trial just stopped, so we should be actually getting the data relatively soon. And some of the other ones we are all familiar with, like steroids, IVIG, mycophenolate, Cytoxan, rituximab. Unfortunately, a lot in our field has still not changed in the last decade, and that's why I'm hopeful that a few years down the line, if I'm giving a similar talk at some point, some of the slides would be new, some of the data would be new, and our treatment approaches would have been influenced by hardcore randomized controlled data rather than retrospective data or expert opinion. So going to my first case, this was a patient who I had seen some time back. The patient was initially sent home from the emergency department first time because the concern was that would this be functional? Patient came back, became worse, had developed altered mental status. This was 10 days following elective abortion. She was confused, agitated in the ER. Neurology consult was called. Clearly something was going wrong. So the patient was admitted, but unfortunately continued to progress and was subsequently transferred to the ICU. CSF analysis was done with a markedly elevated protein at 243 milligrams per DL, as well as some elevated nucleated cells as well. As you can see, it's a bit of a traumatic tap, so you need to kind of do some corrections for the RBCs in the CSF to make sense of whether the protein is truly high and the nucleated cell counts are high. This was the clinical presentation. While the patient is in the ICU, we can clearly see some oral dyskinesias or movements, along with patient is very, very confused or encephalopathic. Patient was hooked up to the EEG and was for their runs of non-convulsive status epilepticus, which were caught as well. Viral studies came back negative. And I think by now, given the age, given the presentation, and given the particular video, many of us already have sort of an idea of what the underlying diagnosis is. And NMD receptor antibody, as suspected, came back positive both in serum and CSF. The patient also had, it was a classic case, had a CT chest abdomen pelvis performed. Given sort of the patient's age group, the chances of us finding ovarian teratoma were relatively high, and we did find it on the CT abdomen pelvis, and which was subsequently removed. This patient was in the ICU, received steroids and plasma exchange, and then subsequently went on to get rituximab as well. So an MD receptor encephalitis, in many of these cases, like this particular patient, MRI is not very helpful. Only 1/3 of the MRI show abnormality. There's a study from Hopkins showing if you have to kind of, some imaging studies, specifically PET scan being useful in these patients, showing occipitoparietal hypometabolism. CSF studies usually in the acute phase are often inflammatory with evidence of elevated protein and cell count, which can be useful. EEG, even though non-specific, can be helpful. There's this scenario of extreme delta brush, which has been described in really, really sick ICU patients. Just one thing to keep in mind, delta brush is not pathognomic of an MDA. I've seen patients with hepatic encephalopathy having delta brush. So again, if you see it in the right clinical context, it can be helpful in sort of getting to the diagnosis. And then, as we know, it's sort of more commonly seen in women, sort of seen at a younger age, but we have seen it quite a few older individuals presenting with an MD receptor encephalitis as well. The tumors tend to be, the ovarian teratomas tend to be mostly in young women. In really, really young cases, where we've reported an MD receptor results in infants, we usually don't find cancers in those cases. Often, older individuals, more than 45 years of age, the frequency of tumors or cancers is relatively low, and most of those usually are not teratomas. We have a patient with nut cancer, a neuroendocrine tumor patient, and a bunch of other cancers which have aberrantly expressed in MDA receptors, and subsequently these patients went on to develop an MDA receptor encephalitis. Something very interesting about the paraneoplastic and MDA receptor encephalitis is it is slightly different in terms of pathophysiology from many of the others, especially the teratoma ones, many of the other paraneoplastic cases, because we have found germinal centers in the ovarian teratomas. It's not just shared immunity where the antigen is presenting by the tumor and the immune response, which is targeting the tumor, getting confused and then subsequently attacking the brain. It's actually antibody making factories are sitting inside these ovarian teratomas, which makes it furthermore important for us to kind of remove these ovarian teratomas along with starting the patients on immunotherapy. The first line immunotherapies are just the garden variety immunotherapies we consider in nearly all our autoimmune encephalitis cases. There are no clear studies which have parsed out what first line immunotherapy is preferred in these cases, but my personal choice in an inpatient setting ends up being steroids and plasma exchange. And sort of, even though many of these patients, it's the typical cases we never see in an outpatient setting. But if you are seeing patients, you can sort of supplement it by IV steroids and IVIG as well. Plex sometimes become challenging, especially in very agitated cases, as well as those having significant dysautonomia, which can be accompanying in some of these patients. But the important thing to remember in most of these cases, you never stop just by first-line therapy alone. Most of these cases do require second-line therapy. A beautiful data comes from a Lancet Neurology study. Most of it was retrospective data, but still very helpful, which showed why use of second-line therapy is critical in patients who are firstly not responding favorably to first-line therapy. So panel C and D are those are the patients who received first-line therapies, were not getting better, and then was subsequently initiated on rituximab. In our practice, we don't even wait for the first-line therapies to kind of show an effect. Nearly all of the patients, along with getting IV solimedrol, finishing the plasma exchange, subsequently go on to get rituximab. Some of the regimens which have other regimens which have been tried are rituximab followed by cyclophosphamide in really, really sick cases. The panel D is an example of that. And some of my colleagues in South Korea follow this SIRT regimen where they not only do steroid IVIG, they also, along with rituximab, they try to do tocilizumab, along with, of course, the removal of the tumor. And we have tried tocilizumab in some of the refractory cases as well. The last therapy, which we'll probably get to know more as the clinical trials results come back, is bortezomib and MDA. And at this point, even though there are some case series, small case series and case reports, hardcore data to support its use is not there. So at this point, we're not actively using bortezomib in our clinical practice. In what subset of NMDA patients are going to do well versus not can be sort of this particular scoring system called as NEOS score can be extremely helpful in sort of giving an idea if you're dealing with a relatively refractory NMDA receptor encephalitis patients. Oftentimes the treatment doesn't really change, for at least for us. We end up doing a similar kind of treatment regimen, but some of the more sicker patients with a higher NEOS score, the patients who are requiring ICU admission, we have sort of at least we have a fair discussion with family, setting expectation in terms of what the long-term follow-up is going to be. It may take a bit more time for patients to regain some of the functional sort of independence. This is a really useful meta-analysis which was published in JAMA Neurology a few years ago, And they identified certain factors which were associated with good outcomes, as well as monophasic course. Some of the ones included adolescent age, so some similar to the patient we talked about, and then sort of use of steroids, IVIG, a plasma exchange, or a combination of the above as a first-line therapy early in the disease course. And the monophasic course, and this is the part which I was emphasizing on, so if, the chances that your patient is not going to have relapses is significantly higher if you're using rituximab in managing these patients along with first-line therapy. There have been cases where instead of doing rituximab, they were doing IVIG, but then extending the IVIG use for a prolonged period of time. The important thing to remember, the two important things to remember with an MDA in terms of setting expectation. It's a slower disease in terms of recovery. So even during the hospital admission or the ICU stay, these patients do improve, but they often take a bit of time to start showing improvement. So probably being more patient in terms of taking those decisions and when to escalate, when to start the third line therapy, the fourth line therapy. Oftentimes we give the patients a bit more time to actually show some improvement before we make that decision for cyclophosphamide or tocilizumab. And then the other things in terms of the long-term improvement, majority of the patients do relatively well as far as the long-term outcome is concerned, but usually patients are left with some deficits. And as reported by the study, 1/3 of the patients don't resume occupational activities. This is sort of after, despite a long term, is suggesting there is some impact on their cognition, as well as the neuropsychiatric aspect of the functioning is impacted. Some of the most common things I see on follow-ups is apathy or sort of behavioral changes, which are long lasting and take a long time to kind of come back. Moving on to our utility of antibody testing in assessment or outcome measures. This study is somewhat controversial because it's a retrospective study, but it shows that in patients who had persistent positivity for MDA receptor antibodies at the 12-month time point, that was the group which had a higher frequency of relapses and also tended to do worse compared to those who did not. But again, we usually don't follow this practice in our outpatient setting, or because most of these patients remain on rituximab at least for the first year. So we don't usually do repeat LPs down the line. And that's one of the concerns that I had with this study as well. Were the patients who were getting LP, were they the patients who were somewhat sicker, and hence sort of persistent positivity was seen in majority of the patients who underwent lumbar puncture. Moving on to our second case, this patient actually came to our clinic. High functioning individual involved in a very demanding job, started having these daily brief lapses in concentration. He described these episodes as brain freeze, where he lost track of conversation for several seconds. His wife noted that along with these brief lapses, he was having episodic involuntary movements characterized by facial grimacing and jerking of the hand. And again, just this description of facial grimacing, jerking of the hands, we should probably many of us should have this red flag in our head. We know what we're talking about. And along with these episodes over time, he started to notice cognitive changes, cognitive dysfunction, word recall difficulties, reduced attention span, some visuospatial deficits as well. And then the sodium was found to be low. MRI showed some T2 flare hyperintensity. This is a textbook case of the thing we are talking about. And this was his video. Interestingly, his grimacing and jerking movements was not just on one side. You can see there's sort of those jerking movements affect the left side as well, even though they're predominantly on the right. And again, in this particular case, once we saw this, we didn't even wait for the antibody results to come back and started the patient on immunotherapy in the form of IV Solimedrol. He also received, he was admitted to the hospital. He also received plasma exchange. And by that time, the antibodies came back, plasma exchange and steroids had actually resolved these episodes. He had already started to notice significant improvement. Subsequently, we started on mycophenolate mofetil and discharge. And during the first follow-up we had, he was nearly back to baseline, back to working and doing relatively well. And that's something which we've seen in many other LGI1 encephalitis cases. So this was a classic example of faciobrachial dystonic seizures with involvement of face and arm. The important thing to remember with these seizures is we often forget the leg, and about 1/3 of the patients with faciobrachial dystonic seizures also have crural involvement. And imagine having these dystonic movements affecting your leg nearly 100 times a day. These patients often, unfortunately, have significant falls. We've had patients with lacerations, subarachnoid hemorrhage from these falls. So that's an important question to ask and carefully evaluate if your patient with BDS has leg involvement as well. It's a disease which happens more commonly in older individuals, specifically men. And other than faciobrachial dystonic seizures, the other seizure etiologies which we see in some of these cases, one of them is pilomotor seizures with goosebumps, often affecting just one side of the body. These sort of vague multifocal sensory seizures, which are the hardest to diagnose. These are the patients who come to the emergency department and are sent home saying this is probably functional. And then subsequently, there's stereotypy of these episodes. And in some cases, the EEG correlate ends up leading to the diagnosis. Or down the line, if these remain untreated, the seizures, patients start developing the encephalitis or the cognitive impairment aspect of things as well. And then we've had cases of ictal bradycardia. I remember one of the patients where the ictal bradycardia was so severe that the patient required a pacemaker, despite getting a diagnosis of LGI1 antibody-associated encephalitis. He also required a pacemaker placement as well. This used to be considered a monophasic disease, but now we know nearly 40% of patients, or I would say more 30 to 40%, have relapses. And we are actively doing a natural history study trying to understand and predict what factors lead to relapses, and coming up with a scoring system to say who would be at higher risk of developing disease relapse. But irrespective of that, these patients not only require first-line therapy treatment, they often require long-term immunosuppression as well. And subset of patients go on to develop chronic epilepsy. These are patients usually with lesional MRI changes upfront, or those patients who are not treated for a prolonged period of time. Some of the risk factors associated with epilepsy, chronic epilepsy, in one of our studies, which published a couple of years ago, was female sex and earlier age of onset. And as I said, we are doing a larger study of 200 patients, which will probably give us more insights into what are the factors contributing to this. It's a disease which actually does relatively well. This is some data from that natural history study showing how with prolonged follow-up, you're starting to see that the modified Rankin score, the proportion of patients with good modified Rankin score, that's a MRS of 0 or 1, or even potentially 2, that's the majority. And then those worse MRSs keep shrinking as time goes on. The same happens to the cognitive aspect of things as well, where the CDR score, that's what we've utilized for this particular study. We see more CDRs of 0, or cognitive dementia rating scale scores of 0 or 0.5, and less of the more higher CDR scores as time goes on. But still, as this shows, not everybody does well. So early diagnosis and aggressive upfront treatment ends up being very important. And then things which are associated with worse cognitive outcome or worse cognitive burden are some things which actually make a lot of clinical sense. Older age of disease onset, much more severe disease presenting with confusion, interestingly dysautonomia, higher CDR or higher cognitive impairment upfront, and then seizures control at last follow-up, suggesting potentially untreated or undertreated patients. So these are things we can keep in mind while devising our treatment plans, but also having discussions with families instead of setting expectations and trying to think what the patient would look like a year down the line. In terms of treatment, we had done a randomized controlled trial. This was quite a few years ago, where we had a bunch of patients who who had potential contraindications to receiving steroids, older individuals with osteoporosis, diabetes, where steroids could not be given. We tried to prescribe IVIG, but kept getting pushback from insurance, which sort of to some extent runs the practice in US. And that was one of the motivations for devising this IVIG trial. What we showed was IVIG was useful and performed better than placebo in both reducing seizure frequency, which was assessed by responder rate, 50% reduction in seizure frequency. There's also a hint of changes in terms of the cognitive impairment, even though not statistically significant. But the other thing we learned from this study is IVIG is probably not the best first-line therapy for these patients. Even though it works better than placebo, it still really doesn't work excellently well, or really well. And that's why in most of the patients, we actually tend to favor using steroids. And some of the data for early immunotherapy use, specifically steroid use, comes from studies from Dr. Irani. This is a very useful study showing how early treatment reduced facial-brachial dystonic seizures as well as cognitive impairment, and then highlighting the importance of using immunotherapy along with anti-seizure medications, and not sort of in these patients just using anti-seizure medications does not reduce the frequency of patients with sort of facial-brachial dystonic seizures. The same can be implied on cognitive impairment as well, where immunotherapy is critical, and specifically early immunotherapy is critical. So these are some of the treatment regimens that we've utilized, specifically steroid regimens in an outpatient practice, where we stretch the treatment out for a period of 3 months. Oftentimes, even if we do rituximab or mycophenolate, these 12-week regimens, in some patients, some cases 6-week regimens, end up being useful in covering the patient for the first few weeks before mycophenolate becomes effective. And these are the regimens we tend to utilize in some of the seronegative cases as well, when we're using treatment as a diagnostic tool to try and help understand whether there's ongoing active inflammation in the brain contributing to the patient's symptoms. Moving on to our third case, and this is a gentleman who presented with ringing in the ears, followed by sensorineural hearing loss. Also developed dizziness soon after. MRI brain initially was found to be normal, was diagnosed of labyrinthitis and treated with steroids, low-dose steroids and acyclovir, sent to vestibular rehab. Interestingly, the steroids did improve some of the ringing in the ears initially, but down the line, he started developing other symptoms like diplopia, nystagmus, ataxia. On the right side, you can see his subsequent audiology testing, where he's showing significant right-sided hearing loss. But the MRI continued to be normal. A CSF analysis was done because by this time, when the patient had developed diplopia and ataxia, patient was being seen by a neurologist. CSF showed markedly elevated cells, or elevated cells as 17 cells per DL, majority of them being lymphocytes, and marginally elevated protein as well. Some of the initial antibody testing, including the paraneoplastic panel SEND, we're talking back in 2015, 2014, those came back negative. But what we did see was this unique staining pattern on thin sections of mouse brain. This particular region right in the middle, which looks like dark, is probably a ventricular space in the mouse. And then this is the periventricular region where you see these small fine dots, which we fondly used to call sparkles. A couple of years ago, we ended up discovering that sparkles truly stood for Kelch-like protein 11, which was the antigen where all these antibodies were binding, leading to this very unique staining pattern on mouse brain. Most of the patients in this paper and some of the subsequent papers have looked somewhat like this particular individual I just described. It's one of the, in this particular case, scrotal ultrasound was done, which came back unremarkable, some tiny specks of microlithiasis. Subsequently, we did a PET scan, which showed this lighting up tumor in the mediastinum, which on subsequent resection came back to be seminoma. So I'm just going to give you a couple of video examples of some of the other patients. This patient came in complaining of oscillopsia. You can see the vertical nystagmus. And then this patient came in complaining of, he actually didn't complain of much other than sort of the dysarthria, ataxia, diplopia. But the physical finding, exam finding, was incidentally found when I asked them to open their mouth. And you can see at the back of the throat that the palate is moving up and down. And these patients sometimes can have disruption of the Guillain-Barré triangle because of the brainstem localization of this disease. Unfortunately, the sad part is our typical palatal tremor patients complain of clicking in the ears, but these patients often have sensory neural hearing loss. It's a T-cell mediated disease, and why is it important to recognize it's a T-cell mediated disease goes to the treatment regimens we tend to utilize, the pathology from one of the patients showing significant T-cell infiltration, some of the PBMC activation studies we've done showing activation of cytotoxic T-cells, including memory T-cells in some of these patients. Excuse me. This particular patient was treated aggressively with IV Solimedrol. Along with that, we started cyclophosphamide early, and the cyclophosphamide was continued for an extended period of time. And this was one of the few cases where we actually saw significant improvement, which could be due to relatively early treatment initiation and aggressive treatment initiation in this particular patient. In most of these high-risk paraneoplastic antibodies, which used to be called as onconeural antibodies, which are suspected to be T-cell mediated diseases, our preferred regimen is this, steroids along with cyclophosphamide. Whereas the cell surface ones that we were talking about before, NMDA, LGR1, we do favor rituximab. This is the regimen we utilize. I tend to favor using oral Cytoxan over IV. I just personally had better experience in terms of managing the dosing as well as the side effects. If you utilize this particular dosing regimen, your patients don't need to be on Mesna. So that sort of also makes it easier to utilize in an outpatient practice. In some cases, we do use IV, but as I said, there's no significant difference based on some of the vasculitis literature between oral versus IV. So we tend to favor oral cyclophosphamide. The only evidence or somewhat useful evidence comes from this clinical trial, which was done by one of my colleagues, Steve Bernino, where they compared patients who were getting plasma exchange followed by oral cyclophosphamide to patients receiving plasma exchange followed by standard cytotoxic chemotherapy in patients with paraneoplastic autoimmunity. It did not reach statistical significance. It was a 20-patient study, but you can see the arm A receiving cyclophosphamide, the rates of improvement were higher, but so were the rates of hematologic toxicity. There have been subsequent retrospective series, including some of the studies done by us, including the papers published on Kelch-11 autoimmunity or anti-U or ANA1 autoimmunity, which have shown cyclophosphamide may be the way to go for these aggressive T-cell mediated disorders. And then none of the talks about these T-cell mediated conditions is complete without briefly touching base on immune checkpoint inhibitor related encephalitis. This is a very useful meta-analysis systematic review of all the published literature on ICI-related encephalitis. The important things to keep in mind are which ones to be more aggressive about. Those are the ones with either patients with underlying lung cancer, specifically small cell lung cancer, patients with encephalitis, which is more focal, regional, such as limbic encephalitis, diencephalic encephalitis, or those with underlying antibodies. Those are the ones you need to be up and aggressive in addition to stopping checkpoint inhibitors. They require steroids and sometimes second-line therapies as well. I've had patients that we needed to start cyclophosphamide. And one such example was this individual who came in with a diagnosis for second opinion for myasthenia gravis because he'd got checkpoint inhibitors and started developing diplopia. But in addition to diplopia, also had disequilibrium. And I've never seen a myasthenia gravis patient do that. That's kind of an example of a wing beating tremor, suggesting brainstem localization. Also, he was found to be significantly ataxic. And in this particular patient, despite his esophageal cancer, which is not the cancer I was talking about with Kelch-11 encephalitis, the patient came back positive for Kelch-11. And that's another key take-home point I wanted to highlight, that in the setting of immune checkpoint inhibitors, all rules go out of the window, and we're starting to see antibodies which we haven't seen before in association with some of these cancers because the checkpoint inhibitors open the floodgate. And then lastly, you don't necessarily, the presence of antibodies is not required for a diagnosis of autoimmune encephalitis. The 2016 Ralf criteria does a good job in describing the seronegative probable autoimmune encephalitis. Another good example is our seronegative limbic encephalitis cases, which I think if you are seeing a very clear radiological appearance of a limbic encephalitis, CSF, and clinical profile suggesting that most of these patients, we don't, as I said, don't wait for antibodies. And even if the antibodies are negative, we don't necessarily change our treatment or game plan. This is a study done by some of our South Korean colleagues, sort of discussing their data in terms of the experience with treating seronegative autoimmune encephalitis. And what they also described a score called as the RAPID score, which discussed various factors which were associated with poor 2-year outcomes that include refractory status epilepticus, older age, probable seronegative AE subtype instead of limbic or ADEM subtype, infratentorial involvement, or delay in immunotherapy. At least the first 4 could be potential factors that you can keep in mind in terms of deciding how to treat some of these seronegative autoimmune encephalitis patients. These are, as I was saying, some of the ongoing clinical trials which are actively enrolling and will likely influence our treatment regimens hopefully very soon. Extinguish CLO and Generate Boost are all, based on the last discussions I've had, are still enrolling. Legion just closed. We are actively looking at the data, including titration studies, and should be coming out with the results of the Legion study hopefully soon. With that, and sort of some of the take-home points, if the clinical presentation is consistent, as I said, the radiological picture or some facial brachial dystonic seizures, we don't necessarily need to wait for antibodies to come back to start immunotherapies. So a lot of data in terms of what to start, how to start, especially for second-line agents, is defined by the type of antibodies, NMDA receptor being one of the examples where second-line therapies are critical. And we often don't wait for first-line therapies to start showing response or lack thereof to start rituximab. Rituximab has become a first-line therapy, at least in our practice, for most NMDA receptor encephalitis patients. And there's data behind use of tocilizumab, cyclophosphamide, and hopefully down the line, bortezomib as well. LGI1 antibody encephalitis, usually the preferred regimen is steroids, despite the IVIG trial we did. Steroids are our first-line therapy regimens. IVIG can be useful in patients where steroids are contraindicated. I've tried it in patients with very poorly controlled diabetes or severe osteoporosis. Relapses do occur in LGI1 autoimmunity, so these patients do require immunosuppression. My preferred regimens include mycophenolate and rituximab, and hopefully some of these trials will give us more data to support use of some of the IL-6 receptor blockers as well. And then as far as high-risk paraneoplastic antibodies are concerned, the regimens and the treatment paradigms haven't changed much. No ongoing clinical trials are actively looking at these diseases because of their rarity and the aggressive refractory nature of these diseases. We are thinking and working on T-cell tolerization therapy trials for some other diseases, and hopefully will influence the treatment of these conditions down the line as well. But for now, for most of the high-risk paraneoplastic antibodies, steroids and cyclophosphamide is the way to go. If you're seeing these patients in the setting of immune checkpoint inhibitors, stopping the ICI and never giving the ICI again to these patients is going to be a critical part of the game plan. Unfortunately, some of the patients who've had re-challenge with ICI have not done well and died from the neurological disease before the cancer takes hold. And then, as I said, multiple multi-center clinical trials are ongoing, and then we need more with creative recruitment strategies so that we can actually look at this data and define our practice through randomized controlled trial data. Thank you, and with that, I'd be happy to take questions.
Thank you very much, Professor Dubey. I think we can take a couple of questions.
Thank you, Prof Dubey, for that excellent talk. So, in follow-up, how long do you continue immunotherapy in patients with autoimmune encephalitis?
So
How
in
many
most
years?
of the in most of the patients, we at least continue it for the first year. I've had patients where the duration of therapy is longer, and some of these are LGR1 patients where when I started to taper off or stretch out our rituximab regimens, they relapsed. The exception to this rule is some of the seronegative limbic encephalitis cases, where the data has shown that many of those patients don't have a progressive disease or don't have a relapsing illness. And in those patients, the duration of immunotherapy ends up being shorter. And I've sort of stopped therapy in some of these cases at 6 months as well.
Thank you. Yeah, good morning. Thank you very much for the platform, wonderful platform. The question I want to raise on teratoma. Frequently we are seeing benign teratoma and the management, as you mentioned. Yes, we proceed with rituximab and immunosuppressive treatment. But I came across a patient who had malignant teratoma at the age of 16. In addition to debulking surgery, what else you specifically mentioned on the management plan?
In many of those cases, I think the management plan is somewhat defined by the oncologist in terms of how aggressive they want to treat with chemotherapy and or radiation. And in that scenario, it might not be as big a problem for using rituximab, but cyclophosphamide ends up becoming more of a challenge given the risk for hematological toxicity with chemo as well as cyclophosphamide. But to answer your question, many of those cases are sort of utilize the expertise of our oncology colleagues to kind of determine a chemotherapy regimen to make sure that we wipe off all the cancer in the system along with immunosuppression.
Thank you.
I have a small question. That is, we have noticed patients who had autoimmune encephalitis, they continue to have seizures despite treatment. And we were wondering, whether there's an entity called autoimmune epilepsy, because some of these patients, they don't really develop relapses as such. They don't have the typical, the autoimmune encephalitis picture, but they just come with seizures afterwards, and some of them actually respond to immunotherapy. So what's your take on this entity called autoimmune epilepsy, which of course can come after autoimmune encephalitis? Thank you.
Great question. I think we see it in both scenarios. I've had a few patients with LGR1 autoimmunity who just primarily present with seizures without features of autoimmune encephalitis, and we try to apply the Grouse criteria. These patients won't meet the criteria for autoimmune encephalitis. So suggesting there is an entity of autoimmune seizures / epilepsy, which without significant encephalitis even up front. And then regarding your question, we have seen that as well. A lot of the patients we talked about, specifically NMDA or LGR1 patients, have what we now refer to as acute symptomatic seizures associated with autoimmune encephalitis, where seizures and encephalitis are up front, and then encephalitis gets better. Most of these patients' seizures get better as well. However, in many of the high-risk antibody cases, that's where we start talking about CALCH, as well as some of the GATS-specific limbic encephalitis cases. That does not end up being the case. These patients go on to develop chronic epilepsy. And unfortunately, some of these chronic epilepsies are not necessarily even responsive to immunotherapy, and they're more related to the structural injury caused by the initial T-cell insult. And these can be extremely frustrating in refractory cases because in addition to immunotherapy, they're refractory to drugs, and we've surgically resected a bunch of these patients and haven't really seen good outcomes. So at this point, to answer your question, I do believe in autoimmune epilepsy. In some of these rare, aggressive T-cell mediated diseases, I don't really have a great answer for what we can do to help these patients. Hopefully some of these tolerization therapies and other therapies we're working on, or some of the work from our epilepsy colleagues will shed light in terms of what's the best way to manage these cases.
Thank you very much, Prof Dubey. Let's appreciate Professor Dubey for his clinical expertise and sharing the clinical cases. So that brings us to the end of this session, and the next session will be chaired by Professor Fujihara Gunaratnam.
So next is the plenary session, and the topic would be is actually Mimickers in central nervous system inflammatory demanding diseases, and Professor Fujihara will address you, and he's no stranger to this audience. And
Thank
can I
you very
invite you?
much.
Thank you.
Thank you very much for the introduction. Good morning, ladies and gentlemen. The differential diagnosis of MS and MOSD in MOGAD are quite important, but misdiagnosis, unfortunately, occasionally occur. So in this presentation, I would like to share with you some mimickers of those CNS demyelinating disorders. These are my disclosures. So this is the evolution of the MS diagnostic criteria. And so until recently, every time the McDonald criteria was revised, the sensitivity became higher, which means MRI criteria were simplified. But on the other hand, since the MRI criteria were simplified, specificity was sacrificed. So there may be an increased risk of making misdiagnosis. But as you have heard, so McDonald criteria should be applied to only to typical CIS cases. And again, you should exclude alternative diagnosis before making the final diagnosis of MS. But as you have heard from Professor Xavier Montalban yesterday, the new diagnostic criteria will be published probably later this year. And for the first time, MRI findings to increase the specificity will be incorporated, namely central vein sign and paramagnetic limb lesions. They are highly specific and useful in making the early diagnosis, and importantly, they are feasible in clinical settings. But again, misdiagnosis of MS can occur in our daily clinical practice. Here's a report from US, and 110 cases were referred to these MS centers with the diagnosis of MS, but they eventually turned out to be something else. So you can see migraines, fibromyalgia, and so on. And many of them had already started the disease-modifying drug for MS. So those treatments were unnecessary, and some of them may experience severe side effects of those treatment. And also, they are financial loss. So correct diagnosis is really important. And next one is a report from Europe. In this study, nearly 700 patients presented with the symptoms suggestive of MS were referred to MS centers. And so surprisingly, 1 out of 4 patients were eventually diagnosed with something else. These are the top 3. Number 1 is the non-specific neurologic symptoms in association with atypical MS lesions. of suspected vascular origin. And the number 2 is migraine, and NMOSD placed third. And which factors can predict the alternative diagnosis? This is a multivariate analysis. First, absence of oligoclonal bands. Second, atypical MRI lesions. And third, absence of dissemination in space. And number 4, normal visual evoked potential. Generally speaking, if your patients with the suspected diagnosis of MS, if they are oligoclonal band negative, you may suspect the diagnosis, but oligoclonal band positivity may depend on the HLA type. As you see here, DLB1*1501 OCB positivity is very frequently seen, but on the other hand, DLB1*0405 oligoclonal band positivity is much lower in frequency. And here's the Japanese data. For patients, DLB1*1501, over 80% were positive, but in patients with 0405, just half of them were positive. So depending on the HLA types, the frequency of oligoclonal band positivity may vary. So here's another report from Middle East. So psychogenic symptoms and other brain MRI abnormalities and is this NMOSD? So many other disorders may be misdiagnosed with MS. And also a report from Latin America. I did not go through all of them, but they are often misdiagnosed with MS. So these 2 cases were eventually diagnosed with something else. But for example, here you can see the symmetric central pontine lesion, which is atypical for MS. And in this case, so white matter lesions do not touch the cortex, do not touch the lateral ventricle, and most of them were smaller than 3 millimeter in diameter. But in other words, periventricular lesions in MS touch periventricle, and the juxtacortical lesion in MS touch cortex. And they are usually larger than 3 millimeter in diameter. But unfortunately, misunderstanding and misapplication of McDonald criteria are not rare. Here, Professor Andy Solomon, who is an expert of MS misdiagnosis, did a kind of a survey. So here's a question. How many periventricular lesions in A, B, and C, and how many juxtacortical lesions in A, C, D, E, and F? The questions were asked to 72 neurology residents and 88 MS specialists. What are your answers? In A, this lesion does not touch ventricle, so the answer is 0. In B, this one touches, this one does not, so the answer is 1. In C, this one touches, and these 2 lesions do not, so the answer is 1. How about juxtacortical lesions? In D, none of these 3, 4, 5 lesions touch the cortex. So the answer is 0. In E, this one touches, this one does not. So the answer is 1. In F, this one touches, this one does not. So the answer is 1. Very regrettably, the correct answers were not so high. In neurology residents, less than 40%, and even in MS specialists, only half of them gave a correct answer. So again, misunderstanding and misapplication of McDonald criteria, unfortunately, are not rare. So misdiagnosis is a big issue. And a few years ago, SLCTRIMS organized a new committee to deal with the issue of misdiagnosis in MS. And these are the steering committee members, including Andy Solomon that I mentioned in my previous slide. And there are 4 working groups. I myself, along with Professor Jorge Coriel of Buenos Aires, Argentina, dealt with the MS differential diagnosis in non-Western geographic regions. This project was quite successful. And since 2 years ago, 3 papers were published in Lancet Neurology and another one in JAMA Neurology. I myself was involved in this and this, but as I said, I was a co-chair of the working group 4, so I would like to mention this work. So non-Western population. So we dealt with MS differential diagnosis in Asia, Middle East, Africa, Latin America mainly. As we have heard from other speakers since yesterday, how about these cases? So longitudinally extensive spinal cord lesions and relatively long optic nerve lesions in the posterior portion of the optic nerve. So these are AQP4 IgG positive NMOSD. And how about the brainstem lesion involving the middle cerebellar peduncle? This is a typical lesion distribution in MOGAD. But in our regions, we may need to pay more attention to alternative diagnosis like infectious disease, nutritional disorders, and genetic disorders. And so these are a number of cases published in this paper. For example, right optic nerve lesion. This is syphilitic optic neuritis. And these spinal cord lesions are zoster myelitis. And you can see the thoracic cord atrophy. This is HTLV1 associated myelopathy, tropical spastic paraparesis. And the multiple enhancing lesion in the cerebellum. This is tuberculoma. And I and J are neurocysticercosis, K and L, neuroborreliosis. These 2 are caused by hepatitis C infection, and this one is brucellosis. Let me show you my own case. So the patient was a 46-year-old male. He came to our clinic with a history of blurred vision since 10 years ago. And Humphrey field analyzer detected right central scotoma. And fluorescent angiography demonstrated the leak in both eyes, suggesting retinitis. AQP4 MOG negative, no pleocytosis, no protein elevation, IgG index is normal, OCB negative. So as you see here, the right optic nerve hyperintensity is seen. But this patient was RPR and TPHA positive. So the diagnosis was the syphilitic optic neuritis plus bilateral retinitis. And he was treated with penicillin G, and the symptom resolved as a result of the treatment. So these patients develop a slowly progressive spastic paraparesis, and dysuria and severe constipation. And the patient was positive for HTV1 in both blood and CSF. And as I mentioned, spinal cord may be atrophic after many years or could be normal. But some of them may develop cerebral white matter lesions. So before this clinical entity was widely recognized, the diagnosis of primary progressive MS was made in some Japanese patients with HAM-TSP. But as you all know, this disease may involve other organs like uveitis, arthritis, Sjogren's syndrome, and some of them may develop leukemia, adult T-cell leukemia. So it's HAM-TSP. And then we may have to pay attention to nutritional disorders and some genetic disorders. Here you can see the cervical cord lesion. This is vitamin B12 deficiency, and these brainstem lesions are caused by Behcet syndrome. And these 4 MRIs showing the extensive white matter lesions are caused by Kedacil. So patients in their 30s to 50s may develop attacks of migraine with aura, subcortical transient ischemic attacks, as you see here, or strokes or mood disorders. And Notch3 gene mutation is detected in these patients. So this is Cadacil, cerebral autosomal dominant arthropathy with subcortical infarcts and leukoencephalopathy. A similar kind of disorder is this. So the clinical manifestations includes recurrent stroke, motor cognitive deficits, alopecia, lumbago, spondylosis, deformance, and the pathology is arteriosclerosis with small penetrating arteries, and the HTRA1 gene mutation is seen. This is Caracil, cerebral autosomal recessive arteriopathy with subcortical infarcts and leukoencephalopathy. You can see a very extensive subcortical cerebral white matter lesions. What are the main barriers to early diagnosis of MS in our region and some other regions like Africa, Latin America, and the Middle East? Well, clearly, awareness of MS symptoms are relatively low among public and even among healthcare professionals. And healthcare professionals who have sufficient training to diagnose MS is also lacking. And diagnostic equipments like MRI, some lab tests are not enough in low and middle income regions. So we have to deal with these issues to improve our ability to make an early diagnosis of MS. There are a number of features which are useful to make a distinction between MS and NMO. And as for the clinical and imaging features of NMO, longitudinal extensive transverse myelitis is a very useful feature to make a diagnosis. But you have to pay attention, and you should be very careful. Here you can see the features more suggestive of MS than NMOSD. So the short spinal cord lesions, and the lesions are localized mainly in the peripheral cord. As you know, NMOSD myelitis is mainly involved central portion of the cord and diffuse distinct proton density or T2 signal changes. Let me show you this case. So this case has short cervical cord lesions, but it's located in the center. So although the lesion is relatively short, this patient was AQP4 positive. A study done by Mayo Clinic group reported that about 17% of the onset NMOSD myelitis may be shorter than 3 vertebral segments. But interestingly, when they experience relapse, over 90% of them show a typical longitudinally extensive transverse myelitis. So as I mentioned here, in these patients, a very long spinal cord hyperintensities, but this is not NMO. This is a primary progressive MS. So short or long may not be directly associated with that, may not be directly linked to the diagnosis. You should be careful. And there are some other diseases mimicking NMO, longitudinally extensive transverse myelitis. How about this? Long spinal cord lesion, but you see a number of flow voids. They are spinal dural AVF. And these patients also have long cervical cord lesions, but this is an axial plane image. And by Mayo Group, it's named trident sign, which suggests a sarcoid myelopathy. And how about this? This is also cervical cord lesions and typical inverted V sign. This is subacute combined degeneration or vitamin B12 deficiency. This is also a long spinal cord lesion, but the symptom develop subacutely or chronically, and this is astrocytoma. As you see here, even if you see long spinal cord lesion, typically in NMOSD, a number of different disorders may develop long spinal cord lesions. In addition to autoimmune inflammatory diseases, as I mentioned, infectious, neoplastic, metabolic, vascular, and others. Brain lesions in AQP4 positive NMOSD may vary from one case to another, but you need to know that roughly 10% of NMOSD patients may have MS-like lesions. So you have to evaluate all available information. As for MOGAD, Professor Sherry Hemingway and Professor Owen Flannagan already mentioned that the clinical and imaging features. Here, I would like to draw your attention to MOG IgG detection. So live cell-based assay is preferable. And even if the antibody's status is judged positive, if the antibody's titers are low, they may include both MOGAD and something else. You should be careful. Occasionally, your patients may be seronegative, but CSF positive. And over time, the patient serostatus, although they may be positive initially, but over time, they may turn to negative. So seroreversion may be seen in some patients. Here's, I show you reports on the CSF restricted MOG IgG. The percentage ranges from 0% to over 23%. It may depend on the patient cohort, timing of sampling, and detection methods and cutoffs. But to resolve this issue, we are conducting an international collaborative study to address this issue. And Ankatri Probestel and the colleagues recently reported MOG IgA positivity. And these patients are, some of them are MOG IgG negative. For example, 6% of the patients clinically diagnosed with NMOSD were MOG IgA positive. but they were MOG IgG negative. And more recently, German group reported MOG IgG3 positivity. Usually, MOG IgG we detected are mainly MOG IgG1. So you have to think about these things before making the diagnosis of NMSD. To sum up my talk, so all available data, but clinical, imaging, laboratory data should be evaluated to make a diagnosis. And McDonald criteria should be applied to typical CIS cases. And we should recognize that not a single biomarker is pathognomonic for MS. And unfortunately, misdiagnosis can occur and is not rare. And alternative diagnosis should be carefully ruled out. And finally, probably there are some diseases and phenotypes that are not recognized yet. So I would like to encourage young Sri Lankan colleagues to discover new clinical entity, new phenotypes of known diseases. I expect you to discover a new disease, new phenotypes in the near future. Well, thank you very much.
Thank you very much, Professor Kazuo, for that excellent lecture, as well as promoting our junior colleagues and us on new research and new findings. So I think we will get a few questions from the audience.
Yesterday, after the sessions, I met some young colleagues in this society, and I told them to ask questions on day 2. So I expect some of them will stand up and come to the microphone. May not be very young, but
not the youngest. Yes.
Sorry.
Thank you, Professor Fujihara, for that excellent lecture once again. With regard to MOG antibodies, would you recommend that we test both CSF and serum because some are seronegative? Or if we are to test one, which one would you recommend because we are resource poor and restricted by the number of tests that we can do?
Yes, it's a critically important question. If both serum and CSF are available, ideally collected during acute phase before the acute phase treatment is started, I think we had better test both. But you may have just serum, or occasionally you may have only CSF. Then you can test one of them. But as I mentioned, depending on the methods, patient cohorts, cutoff, and so on, the percentage, frequency of those CSF restricted MOG IgG cases vary from 0% in some studies to more than 20%. So if you are unsure about the results that return to you, you may send the sample to some other lab to confirm the results. That's what I can tell you at this point.
Thank you, Professor Fujihara. I'm not young either. I have a question regarding MOG encephalitis. I think we are understanding
MOG encephalitis.
Encephalitis.
Cerebral cortical encephalitis?
Yes, cortical encephalitis, and with the features defining like a syndrome, what do we understand about the long-term outcome? Do they also respond like we expect in other MOGADs to be a monophasic illness? Or what's your experience about long-term outcome in those who have cortical MOGAD encephalitis?
Well, I think that I asked that questions to Professor Owen Flannagan, but in our own experience, some of them may experience a recurrence of cerebral cortical encephalitis, and others later may develop other clinical phenotypes like optic neuritis. So it varies, and from the therapeutic point of view, so since many of them develop seizures, they are initially treated with anti-epilepsy drugs, but anti-epilepsy drug alone usually is not effective. But after IV methylprednisolone, the seizures subside. And as for the hyperintensity seen on the unilateral cerebral cortex, they usually disappear after a few months or after several months. So that's my own experience.
Sorry, one more question on that. When they come back with relapses, do you find lesions reappearing on the cortex? And also, have you described or is there evidence to say that this would lead to autoimmune epilepsy?
Yes, this is an autoimmune epilepsy, and some studies show that MOG positive cerebral cortical encephalopathy, cerebral cortical encephalitis is more common than NMDA receptor encephalitis. So it seems to be the commonest autoimmune encephalitis among various types of diseases. And so, as I said, some patients may experience a recurrence of cerebral cortical encephalitis, but others may develop other clinical phenotypes like optic neuritis.
Thank you.
Kazuo, just to follow up on that same question Jitang asked, didn't Eoin say that like about 70% of them will relapse as opposed to optic neuritis? Out of the phenotypes, MOG phenotypes, the encephalitis phenotype, do they relapse more?
Well, probably the clinical phenotype associated with the most frequent relapse may be optic neuritis. Maybe after more than a few years ago, you told me to present the topic of CREON, chronic relapsing inflammatory optic neuropathy. And it turned out that the majority of the patients who were diagnosed with CREON were MOG IgG positive. For example, in my own case, patient in his 70s, since he was in 50s, 8 episodes of optic neuritis, right and left. And every time his corticosteroid dose were reduced or tapered off. And then he was referred to me, and I measured the MOG IgG, and he was positive. So I told him not to stop the corticosteroid. But for some reason, ophthalmologist who referred the patient to me discontinued the corticosteroid again. So I said to the patient that, well, you may experience another optic neuritis relapse. But for some reason, since then, more than 5 years have passed. This time, without any corticosteroid, he has been relapse-free. So it's not easy to predict the clinical course of the disease.
Thank you very much, Professor Kazuo. I think we all would like to continue this discussion further, but with the interest of time, we'll wind up for tea now. And I hope we would meet back in 10 past 11. Thank you very much.
Welcome to the symposium number 5 on neuro-ophthalmology of demyelinating disorders. We have 2 topics this morning. The first topic will be by Professor John Chen, who is the Professor of Ophthalmology and Neurology at Mayo Clinic, Rochester. Prof Chen will talk to us on diagnostics and therapeutics, dilemmas in optic neuritis. Over to you, Prof Chen.
Hello, everyone. Thank you for that kind introduction. Today, I'd love to talk to you about optic neuritis, and This group is well aware of these three defining disorders, which obviously this conference has really culminated all our knowledge about these. We've got MS, NMOSD, and MOGAD. And we recently did a population-based study using the Rochester Epidemiology Project to determine how common these various etiologies account for optic neuritis in a predominantly white Caucasian population. And as you can see here in using the Rochester Epidemiology Project, about 50% of optic neuritis is MS, 5% is MOG, 3% NMOSD. About a third is actually idiopathic, as in there's probably some antibodies that we actually don't know yet. And then 6% were others, including infection, sarcoid, seronegative NMOSD. It's interesting, there was a study, a collaborative study between Mayo Clinic and Sri Lanka, where it was determined to find how many patients were from of optic neuritis were from MS, MOG, and NMO. And as you can see here, is actually a quite striking difference compared to what we found in Rochester, Minnesota, in the United States, where in Rochester, Minnesota, it was only 5% MOG. In Sri Lanka, MOGAD was actually the most common cause of optic neuritis at 17%. MS was 10% and NMO was 5%. And so again, it's interesting that different populations have much different etiologies of optic neuritis. And in Sri Lanka, you're going to be seeing a lot of MOG. In Africa and parts of Asia, you're going to see a lot of NMOSD. And again, MS is going to be less common in these populations that have less white patients. So we're going to step through each of these causes of demyelinating optic neuritis and point out some characteristics that would make you think MS, NMO, and we'll spend most of the time talking about MOGAD. And so for multiple sclerosis, that is, again, the most common cause of optic neuritis in white patients. And so the landmark clinical trial, the optic neuritis treatment trial, MS accounted for about 50% of their optic neuritis. With MS, it tends to be young adult females. Whites are more affected than Black and Asians. And with optic neuritis with MS, it tends to be unilateral. The vision loss tends to be more on the mild to moderate side. 90% have eye pain. Typically, patients have good recovery. And we look at the optic nerve, only a third have optic disc edema. And if there is disc edema, it actually tends to be more mild, similar to this photograph right here. And when you have enhancement of the optic nerve, it tends to be a short segment of optic nerve enhancement. And of course, with MS, you have the classic periventricular white matter lesions that are very characteristic of MS. And in terms of treatment, we often do use steroids for MS optic neuritis. But what's interesting is that the optic neuritis treatment trial, the ONTT, actually showed that the IV methylprednisolone led to faster recovery, but didn't actually change the ultimate outcome. And so essentially, if you have a patient with very classic MS-related optic neuritis, and it's on the more mild side, we do have the option of observing, and these patients tend to recover. And again, the steroids allow for faster recovery, but actually didn't change the ultimate outcome. Going back to our three main etiologies, now we're going to step in and talk about NMOSD and how that differs from MS. We recently, this is a study not published yet, but we recently looked at 244 optic neuritis attacks from NMOSD seen at the Mayo Clinic, aquaporin-4 positive. And similar to other studies, there is a vast predominance of female patients affected by NMOSD, 85%. That's even more female predominant than what we see with MS. The median age of our cohort was 40, which is about a decade older than MS, and again, similar to what other studies show. Interesting, in this cohort of optic neuritis from NMOSD, eye pain was only seen in 59%. So that's actually less than we typically see with even MS optic neuritis, where it's reported to be as high as 90%. And perhaps some of that is because with NMOSD, sometimes the optic neuritis is more posterior, sometimes even affecting the optic chiasm, away from the orbit and muscles where there's more pain. And so that might be why they sometimes have less eye pain. In support of that, actually, only 24% had optic disc edema at onset, compared to 1/3 for MS. So maybe some of these more posterior lesions are why there's less eye pain, less disc edema. Unlike multiple sclerosis, where bilateral optic neuritis maybe only accounts for 2 to 3%, With NMOSD, it's 20%. So anytime you have a patient with bilateral optic neuritis, you do want to have NMOSD higher on the differential diagnosis, because that'd be unlikely MS. And we all know that NMOSD causes quite severe vision loss with their optic neuritis attacks. In our cohort, the median visual acuity at nadir was count fingers. And the median final visual acuity of our cohort was 2100, with 46% of patients ending up 2200 or worse. If you compare that to typical optic neuritis or MS optic neuritis, only 3% of patients end up 2200 worse. And so this is magnitudes worse. NMOSD is magnitudes worse than MS-related optic neuritis. And really, NMOSD does cause blindness in a large percentage of our patients. And that's why for patients with NMOSD with an acute attack, we not only use IV corticosteroids, but we usually use plasma exchange as well. And this group knows that plasma exchange, in terms of the mechanism, is thought to remove the pathogenic substances like the antibodies, immune complexes, and cytokines. And this is thought to essentially remove the pathologic OCT4 antibodies and cytokines and hopefully lead to better recovery. We recently did a large international multi-center retrospective study of about 400 optic neuritis attacks. And we had 75 patients with OCT4 positive NMOSD optic neuritis that was treated with Plex. And you can see here that at presentation, they presented with very severe vision loss of count fingers vision. And after plasma exchange, the median visual acuity was 20/30. So again, plasma exchange was associated with significant recovery in these patients with NMOSD, and better outcomes were seen when Plex was given within 1 week of symptom onset. Again, these are retrospective studies, so we still need larger prospective studies, which we'll talk about in the future. But again, this is further evidence suggestive that plasma exchange should be given to these patients, because we know the natural history of this disease is so severe and so bad. And now we're going to talk about MOGAD, and then we'll talk about treatments as well. With MOGAD, this is just a classic case of MOGAD optic neuritis. This is a 48 male who presented with blurred vision and pain in both eyes. And on fundoscopic exam, what you can see here is bilateral disc edema, probably grade 3 disc edema, even with some peripapillary hemorrhages here in the eyes. And oftentimes when we see bilateral disc edema, sometimes we think that this might be papilledema from raised intracranial pressure. But this patient with count fingers, really severe vision loss. And so this is vision loss is out of proportion than what you'd expect from papilledema from raised intracranial pressure. And this should alert you to get an MRI of the orbits looking for optic neuritis. And in this patient, what you can see here is profound enhancement of the optic nerves, both optic nerves, with the enhancement so profound that it spills into the periorbital fat, as you can see here, which we call periorbital enhancement. And this is a very classic finding in what we see in MOGAD optic neuritis. So when we look at our broad differential diagnosis of optic neuritis, if you have a patient with this much disc edema, with this much perineural enhancement, I would have MS way, way down in the differential. And I would actually have OCT4 NMOSD quite low on a differential diagnosis as well. At the very top of the list is going to be MOGAD, but we also want to have other potential etiologies of optic neuritis on a differential that can present this way, including sarcoid, lupus, granulomatosis with polyangiitis. We want to think about our infectious mimickers like Lyme, syphilis, TB. And I might have infiltrative processes on the differential as well, and idiopathic. Again, antibodies that we just don't know yet could potentially present this way. But again, if you see this much disc edema with this periorbital enhancement, MS and NMOSD should be much lower in your differential diagnosis, with MOGAD rising to the top. So at the time, it was actually interesting. This patient was seen pretty early in my career at Mayo Clinic, actually before we even had the antibodies, before we even knew that MOGAD existed. And so we diagnosed the patient with atypical optic neuritis. It was atypical because bilateral optic neuritis is rare in adults, and the significant disc edema is rare. You know, what we learned from the ONTT is that, again, only a third of optic neuritis have disc edema. And when it's present, it tends to be very mild, like grade 1 disc edema. So again, this was atypical. The patient had a workup looking for oligoclonal bands, OCT4 antibodies, which were not unsurprisingly negative. And the infectious and inflammatory workup was negative as well. The patient was treated with 1 gram of IV methylprednisolone for 5 days. And again, the vision when they presented to the hospital was count fingers. And within 3 days of the IV steroids, the patient was back to 20/20. And that's actually quite atypical for optic neuritis from multiple sclerosis, where we know that IV steroids leads to faster recovery, but maybe instead of taking 1 to 2 months to recover, the recovery happens in 2 to 3 weeks, but usually not within 2 or 3 days. But MOGAD optic neuritis can be very steroid responsive, and we often see that. Unfortunately, this patient had multiple relapse when the patient was tapered off prednisone. And again, that's a pretty classic feature of MOGAD, where sometimes they're not only steroid responsive, but they can be steroid dependent. And at the time, because we didn't know MOGAD existed, the patient was diagnosed with chronic relapsing inflammatory optic neuropathy, or CRIN, which is by definition a steroid responsive, steroid dependent optic neuritis that's idiopathic. The patient was stabilized on azathioprine 100 milligrams twice a day with no further relapses. And not surprisingly, once we had an assay for MOG, the patient was positive 1 in 100. And again, this was a very classic case of MOGAD. So with MOGAD, really the most common presentation is optic neuritis. And we're just going to step through some of the ways, features that make you want to think that this is going to be MOGAD. 50% are bilateral. So actually with MOGAD, it's actually more commonly bilateral than even NMOSD, which was 20%. And again, with MS, it's about 2 to 3%. So again, if you see bilateral optic neuritis, MOGAD goes to the top of the list, and then I have NMOSD as second. 50% of the time it can be recurrent and often steroid dependent. We now know that MOGAD explains about a 50% of what was previously idiopathic CRIN. And so they like to have not only be steroid responsive, but sometimes steroid dependent. Another key feature about MOGAD is they tend to have more disc edema. 80% of patients have disc edema compared to only a third with MS optic neuritis and probably about 25% for NMOSD. And we did a study. This is a large multi-center study. Perhaps some of the collaborators are actually here at the meeting at SLCTRIMS, where we compared the OCT RNFL thickness with acute optic neuritis from MOGAD and compared to multiple sclerosis. And what you can see here is that patients with MOGAD optic neuritis had a median RNFL thickness of 164 microns compared to MS, where it's only 103. And so very significantly different. And when we did a receiver operating characteristic curve, we got an AUC of 0.81 in differentiating MOGAD from MS, and a Udens index, 118 microns maximized Udens index, with about an 80% accuracy in differentiating MOGAD from MS, where if it's 118 microns, it's more likely to be MOGAD than MS, where you only have a scattering of patients with MS. And if you raise that bar to 175 microns, you can see that we're still catching about 50% of MOGAD. And it's very specific for MOGAD. So if you have an optic neuritis, there's about 200 microns of RNFL thickening at the time of the acute optic neuritis attack. You can be fairly sure or much more confident thinking that this is probably going to be MOGAD as opposed to multiple sclerosis. And with the observation that MOGAD does tend to have a good amount of RNFL thickening with each attack, we actually used OCT as an objective measure of an acute optic neuritis in the rozanoliximab trial through UCB, where if there's eye pain and some blurred vision, and you have over a 10 micron increase in RNFL thickening, that actually is an objective sign of optic neuritis that can be used for adjudication of the attack. And it's the first time that OCT has been used in a clinical trial to help confirm an acute attack. And it was some of this study here as justification for that. And I think future clinical trials will use OCT in this way. OCT findings are also helpful in comparing MOGAD from NMOSD. And again, that's important because both MOGAD and NMOSD can present with bilateral optic neuritis. Both can present with very severe vision loss at nadir. This was a study led by Pikirathan and Eisenberg, and this was presented at SLCTRIMS. And this is a large retrospective study that we collaborated with this group, where, again, what we're finding is that with MOGAD, we're having much more thickening of the RNFL compared to NMOSD. And you can see this is the scatter plot again, showing that with MOGAD optic neuritis, there tends to be much thicker RNFL with the acute optic neuritis. With NMOSD, it's pretty rare to have a good amount of thickening. And here, just a cutoff of 125 microns actually provided a sensitivity of 62% and a specificity of 97%. And so again, if you see a lot of RNFL thickening, you want to think about MOGAD over NMOSD and MS. Again, so this is your classic kind of feature of MOGAD optic neuritis with a good amount of disc edema. What's interesting is the most common acute optic neuropathy in adults is NAION. And what you can see here is, by definition, NAION has disc edema. And based on these two pictures, it would actually be, I think, quite hard to say which one's NAION and which one's MOGAD just based on the fundus photograph. We know that MOGAD optic neuritis can affect any age, including older adults. So we actually did a study, again, a multi-center retrospective study looking at cases of MOGAD and NAION and comparing them to see if we can have features that would help suggest NAION versus MOGAD optic neuritis. So this was, again, a study looking at 64 MOGAD optic neuritis attacks in patients over the age of 45 compared to age-matched NAION patients, which again is a stroke to the nerve. Again, completely different pathophysiology. But as you can see here, both MOGAD optic neuritis and NAION do have RNFL thickening. What you can see here is that actually NAION has more RNFL thickening than MOGAD, which is not too surprising because by definition, NAION has to have disc edema at onset. It's non-arteritic anterior ischemic optic neuropathy, and that anterior portion means there's disc edema. So again, both MOGAD and NAION have RNFL thickening, but NAION has more. Both MOGAD and NAION, you can see here that MOGAD actually presents with worse vision than NAION, but the outcome it's much better than NAION. With NAION, you don't really have much recovery. And so those are some features. Again, if you have a patient with disc edema and you're trying to think, is this NAION or MOGAD? One, you look at amount of disc edema. If there's a ton of disc edema up in the 400 microns, that might be NAION. If there's a lot of recovery, you want to think about MOGAD optic neuritis because NAION doesn't tend to recover. And then when we looked at other features that kind of help differentiate MOGAD from NAION, really the key features, other than the ones we talked about, which is MOGAD has less RNFL thickening and better recovery, is that MOGAD tends to have eye pain. NAION tends to have crowded discs, and NAION tends to have altitudinal visual field defects. And these are just classic features of NAION. You can see here, this is a patient with NAION in the right eye, and they like to have either superior or inferior altitudinal defect. And again, MOGAD can do that, but it's much less likely. And about 90% of patients with NAION have a crowded optic nerve and that disc at risk that puts them at risk for ischemic optic neuropathy. And so again, these are some features that can help differentiate the two in an elderly patient who presents with acute optic neuropathy. The MRI findings we kind of briefly talked about. With MOGAD optic neuritis, they have optic nerve sheath enhancement. 50% of the time, they actually have enhancement that spills into the orbit, which we call perineural enhancement, which we don't typically see with NMOSD. And the vast majority of the time, you have longitudinal enhancement of the nerve for MOGAD. And so, with the diagnostic criteria published in 2013, International Diagnostic Criteria, if it's a low positive, you need to have at least one clinical or MRI feature. And essentially, these are all the features that we talked about. The bilateral nature, since 50% of MOGAD are bilateral, this longitudinal enhancement of the optic nerve, perineural enhancement, and disc edema. And so again, these supporting features of MOGAD you're going to be looking for. We're going to skip through this here, and we're going to talk about the vision loss. That's why we care. Why do we care about optic neuritis? It's the vision loss. And so as you can see with MOGAD, they do present with severe vision loss at onset, and very similar to NMOSD. But the good part is the recovery is much better. The median visual acuity in our cohort of 242 attacks was 20/20, with only 5% ending up 2,200 worse compared to 46% for NMOSD. But again, you can't go by presenting visual acuity at onset because there is some overlap. We do have some patients with MOGAD presenting with 20/40 or worse. There's even some NMOSD patients that can present with 20/40 or worse. So you can't depend on severity of vision loss at onset to help differentiate the two. The MOGAD definitely has different presentation, prognosis, and pathophysiology, and they have different treatments, and they're often very steroid responsive. And so we're just going to end briefly on some treatments. And one of the big questions is, does early steroid treatment lead to better outcomes? There is a retrospective study by Stibo Kalish, where they found that better outcomes were seen with earlier treatment, but they only had 9 MOG patients. There's another study by the French group that also found this as well. We looked at this with 140 MOGAD optic neuritis attacks. And what we found is that on average, patients had 3 days of eye pain before the vision loss started. Then the vision dropped about 4 days before they got to the natural nadir of 2,600. And fortunately, the majority of the patients recovered to 20/20, but 13% remained 20/40 worse, 5% remained 2,200 worse. So not all patients recovered. When we looked at steroid treatment, what we found is that if patients were given steroids within 2 days, only 2% of patients ended up worse than 20/40, compared to 17% if the steroid treatment was given after 2 days. What's interesting is that the median visual acuity at the time of steroid treatment was much better in patients given steroids within 2 days. So one of the thoughts is that essentially if you're treating them at 2 days of symptom onset, you're actually preventing them from getting them to their natural nadir of 2,600. And so it's suggestive that early steroid treatment may lead to better outcomes. What's interesting is there are 9 MOG patients attacks that were treated with early steroids during eye pain that led to resolution of the pain without vision loss. And 6 of these were actually confirmed to have optic neuritis with MRI with optic nerve enhancement. Gordon Plant and Axel Petzold, who you're going to be hearing about shortly, have previously looked at hyperacute corticosteroid treatment at this time to prevent vision loss. And they looked at 8 optic neuritis attacks and found that it was an effective treatment. Of course, this is before we even knew MOGAD existed. But if 80% of patients with MOG have pain with at least 1 day of eye pain before vision loss, is there potentially a therapeutic window? And we've actually, over the past 4 years, been recruiting patients in a prospective study, essentially giving them steroids, access to steroids, where they can have treatment within 6 to 12 hours of onset of the symptoms. And very early steroids is aborting the attacks. We've recruited about 100 patients so far, have had 20 attacks, and none of the patients have had residual permanent vision loss with this very early steroid treatment. And so this is something that's quite encouraging, that we're offering a lot of our MOGAD patients, because the attacks are not only, they tend to be very steroid responsive, especially if given early. And so, again, with just a summary of the acute treatment in MOGAD optic neuritis, it's IV methylprednisolone or high-dose oral prednisone for 5 days, followed by a low-dose oral prednisone taper. We usually do over about 1 month, but I know some groups kind of extend it for 6 months. Early treatment seems to be associated with better outcomes. And unlike NMOSD, where we really try to encourage plasma exchange very early on, with MOGAD, usually they recover with steroids, but we do want to consider plasma exchange if it's severe and there's no recovery after high-dose steroids. And I just want to end briefly on talking on our large multi-center retrospective analysis of plasma exchange for optic neuritis. Again, here we looked at 395 optic neuritis attacks. And what's nice is the groups were actually pretty equal, where we had about 100 idiopathic, 100 MS, 100 MOGAD, and 100 NMOSD. So we could actually look at these various etiologies of optic neuritis and look at outcomes. Overall, with this cohort, patients presented with severe vision loss with a median visual acuity of count fingers. And after Plex treatment, the median visual acuity was 20/25. 43% recovered at 20/20, 67 were 20/40 or better. But 20% of patients still ended up 20/200 worse. So there is still a cluster of patients that did not respond to plasma exchange. When we looked at the etiologies, what's interesting is that NMOSD, MS, and idiopathic actually had fairly similar outcomes. The only difference with MOGAD had actually significantly better outcomes compared to the other etiologies, but no other differences among the other three. Really, one of the main factors associated with recovery was time to plasma exchange. And you can see here with plasma exchange within 1 week, there's a significant portion of patients who had better recovery, 65%. Compared to patients treated with plasma exchange after 28 days, where it's only 21%. And so again, it's suggestive that early plasma exchange is associated with better outcomes. When we compared a subset of our patients to a subset of equally severe vision loss in the optic neuritis treatment trial, you can see here, this is what we found with plasma exchange in terms of outcomes, and getting an outcome of 20/20 or better. Was actually significantly better at all time points compared to the ONTT, suggesting that plasma exchange does truly lead to better outcomes than steroids alone, especially if given early in that first 1 week or 2 weeks. But again, these are retrospective studies. And so this is the last slide I wanted to talk about. With retrospective studies, there's always the bias in terms of, patients who got early plasma exchange, or those patients destined just to do well regardless, whereas a patient, 1 month into vision loss who's doing poorly, they're already destined to do poorly. And so that's the problem about these retrospective studies. So ultimately, what we need is a prospective randomized clinical trial. And we do have one upcoming, which is sponsored and funded through PCORI, where we're going to have 31 sites enrolling 200 patients with severe optic neuritis, 20/200 worse, and they're going to be randomized within 8 days of symptom onset to either get the traditional rescue Plex, which is initial treatment with high-dose corticosteroids, with escalation to plasma exchange if there's no recovery at 14 days. Compared to actually early plasma exchange right there within a week with corticosteroids. And so ultimately, we really will be able to answer, does early plasma exchange lead to better outcomes for severe optic neuritis? And there's also going to be a sub-trial of transverse myelitis where we're going to be recruiting 182 patients into that. And so definitely look forward to seeing these results and collaborating with these 31 sites in the US, and we'll be able to provide better guidance on which patients would benefit from Plex and how early do they truly need Plex. So I'd like to thank you for your attention. I look forward to the question and answer session that'll be after Dr. Petzold's talk.
Thank you, John. I think we'll move on to the next pre-recorded talk by Axel Petzold, National Hospital for Neurology and Neurosurgery, Queen Square, London, and also Moorfields Eye Hospital, London, and Amsterdam University Medical Center, Netherlands.
Thank you for the invitation to come to Colombo today again. And it's a pleasure to be back after last year's presentation around the same time on the optic neuritis diagnostic criteria. Last year, John and I spoke about the criteria, and then John spoke in more depth about MOG antibody disease. And this year, I thought to repeat a little bit what we discussed last year, only by giving you the visual of the flow charts and then again speak through some practical cases to explain the thoughts behind the criteria and help you in your daily practice applying them. I will make some new points. One will be on progression independent of relapse activity or PIRA, and one point will be on the validation of bespoke criteria since we met last. As a reminder from last year's symposium, the QR code in the slide shows you a link to the slides which are free for download. And I will use also in today's presentation, again, QR codes for you to enable download. Now, the diagnostic criteria for optic neuritis are very simple and very straightforward. They really consist of 3 clinical scenarios, A, B, and C. And these scenarios are then combined with paraclinical tests to make a diagnosis of definite optic neuritis. Once you've made this diagnosis, you can classify it. But this is also the moment to say a big thank you to UCL Library for helping us to make translations available of the criteria. And I hope if you go to the UCL Library, you find some mistakes in these rudimentary translations, do let me know and I will improve on it. And also a big thank you, of course, to the publisher, The Lancet, who has given us permission to try to overcome the language barrier here. Okay, but I said classification, so here we go. Once you made the diagnosis, for clinical practice, probably the most important decision to make at this point is it a relapsing course or is it a monophasic course? Because if it is supposed to be autoimmune and we come into this category where multiple sclerosis is in, that of course has long-term management consequences. Whereas if it had been monophasic, we can say goodbye to it. With that, I come to the application. And the application, again, is simple. You have the clinical scenario, you have 3 paraclinical tests, and then you combine them. The clinical scenario, I will talk you through with the following cases, but I want to make one point at this stage about the paraclinical tests, because 2 of them are imaging based. And it is massively important that you understand the difference for imaging in the acute phase to the chronic phase. So here you can see the imaging of the optic nerve, the left optic nerve, the right optic nerve. And to make it very simple, the intensity, grayness of the optic nerve should be similar to what you see in the white matter. They're both white matter tracks. This is the normal nerve, the same gray intensity. And surrounding it, you have this white signal, which you also see around the brain, and that is the cerebrospinal fluid. This is the normal situation. It is the right optic nerve, which is the pathological one. It is swollen. And as it swells, it presses the CSF to the side, so there is less of the CSF signal. And it's a contrast-enhanced scan, and this nerve does take up contrast, so it does look brighter, and brighter than the white matter here. So here you have, in the acute phase, the left optic nerve swollen, enhancing. OCT may be normal or abnormal if there's swollen disc. OCT is very, very sensitive 3 months after the event. And what I show you on top here is the macular and the disc. For those who have not already seen that the C from this meeting merges into the nerve fiber layer as a red line, in the retina, there are 2 areas which are of interest. One, here in the background, you see the optic disc, for all the nerves come out from the eye and reach the brain. The second one, just as important, is here the foveola. This is the area you now use to see me on the video, and there are no ganglion cells or nerves on top of these photoreceptors to give pristine human vision. All right? So in the normal macula, you have a lot of ganglion cells and nerve fiber layers, and in the atrophied macula, they're gone. And the difference between these 2 needs to be more than 4%. I will come back to the percentage later. The same for the disc. Between the red line and the green line, you see the nerves, and following optic neuritis atrophy ensues, and it is thinned. Now, let's talk through the first case, which you've seen last year. It is a young Caucasian lady in childbearing age, and she gives a history of pain in the right eye, which worsens in eye movement, reduced color vision, reduced vision, clinical and a right RAPD. And RAPD stands for Relative Afferent Pupillar Deficit. Some people refer to it as the swinging light test, and it's also known as the Marcus-Gunn pupil. These three terms are used interchangeable. She gives a history pretty typical for demyelinating disease, and the MRI does show dissemination in space and time radiologically with contrast-enhancing lesions. So to talk you through the situation, we do have the clinical scenario A. It is the monocular subacute loss of vision, it's pain on eye movements, reduced color vision, RAPD. Our clinical test is the MRI, and we look at the application. For scenario A, you just need one test, and you can make a diagnosis of definite optic neuritis. Once you have made that, you go into your classification, and of course, this is multiple sclerosis optic neuritis. It's very, very straightforward. The next case, there is a variation because there is no pain. And painless loss of vision can happen if the optic nerve inflammation happens to be in the intercranial part where there are no nerve fibers and no pain fibers associated. And in this patient, we had also an MRI showing a swollen nerve, and once they were discovered, it was tested positive for antibodies against aquaporin-4. How do you apply the criteria here? It is scenario B, because there's no pain. And you look at the tests, we have the MRI and the antibody. Application for scenario B, you need to have two different tests. This case, the MRI and the antibodies. And you can make a diagnosis of definite optic neuritis. Then you look at your classification and you can see this is aquaporin-4 optic neuritis. When we classified that, we decided to put the name of the antibody antigen, the protein first, and then optic neuritis, because this will allow in future revisions, which they're candidates, easily to add on new antibodies as they are validated to a sufficient degree for experts to accept it, to recommend it in diagnostic guidelines. This is a case you have not seen. It's an elderly lady who received the vaccine against COVID. That was the AstraZeneca vaccine, which is now taken off the market. And 2 weeks later, she developed pain in the eyes with worsening on eye movements. And then there was sequential binocular loss, first right eye, then the left eye. She was not a London patient elsewhere in the country. She did receive steroids with substantial delay about 23 days later when she came to me at Queen Square. And when I followed her up, she actually did make an excellent visual recovery with acuity 6.9, 6.7.4, almost normal color vision over 1 year. She's also part of a paper which only exists at a preprint with the Lancet and is explained in more detail there. So in her, I want to expand a little bit on the OCT because I hope you will learn more about the inter-eye difference, and I will show several slides. In her, I also will make a point about the MRI, which was pathological in the FLAIR sequence, but not in the contrast. And I point on the biomarkers, because generally speaking, we always say there are oligoclonal bands or not. But here, free for download in this paper, there are 5 patterns to the intrathecal IgG synthesis. And in multiple sclerosis, we only expect IgG to be found in the CSF and not in the serum. That is what is helpful in multiple sclerosis. But there are situations where you have systemic inflammation, and then you find the same polyclonal IgG. I simplified that here for visibility in the serum as in the CSF, and that is then, of course, the original, not how it looks on a gel. Now to the combination of the imaging result. There's a lot of information in this slide, and I will talk you through it briefly. The acute phase, in the fundus, you see a very swollen disc. This disc is so swollen on the right that the veins are not only engorged, but you see this typical flame-shaped hemorrhages as with severe edema, less severe on the left. And this is very unusual to see all these subretinal hemorrhages in the macula. You would not expect to find this in multiple sclerosis. The acute OCT, that's the TopCon device, which gives you the fundus photographs, in addition to the OCT through the macula down here and the disc, shows the disc enlarged here, the right one, the left one. You clearly see the swelling all happens between Bruch's membrane, that is the wider part, the outer part of your eye, and the nerves which are here on top. All the fluid sits here dark in the nuclear layer. It comes all the way subretinal to the macula here. So this is a very swollen disc. After 6 months, there's atrophy. All the nerves which are still visible here are gone. This is the peripapillary retinal nerve fiber layer using a different device. That's the Heidelberg spectralis. And in both eyes, you see the atrophy. It's different on the MRI. I mentioned that the flare sequence, which you see here, does show abnormal signal in both optic nerves, binocular. The signal here in the flare is higher than the white matter. That's abnormal. But, and that's an important but for you to realize, in the contrast enhancing T1 sequence, which are fat suppressed, you see here the muscles enhancing, there's no contrast enhancement of the optic nerve. And I will come back to that because this is very important to realize, to just get a feeling of which method is particularly valuable at which time point. Here to talk about retinal asymmetry. Remember, both of the nerves look on the flare sequences brighter, but it would be difficult to make a very good judgment on the thickness. If we then look at the OCTs, and these are 2 OCTs taken a year apart, showing stability of the situation, then you can see there's atrophy on the right and on the left. The value up here should be above 0.4, roughly speaking. The point I want to make with this slide is very important. In the optic neuritis criteria, we just say a 4% difference is sufficient. The easiest for you in clinic will be to look at the volume. 0.2, 0.3, this is a 62% difference, and you're there. There's also the absolute difference. These are the micrometers. There are other criteria under revision where the micrometer cutoff will be taken, but I just want to remind you, if you do so, you will need to add up all these 8 values for each of the eyes, but please don't use the central value because in the foveola, there should be no retinal fiber and ganglion cells. So this is an algorithm failure, which always will be there. So ignore this value, only add up these ones, get your average, and then subtract one eye from the other one. But I think it just takes too much time. So I find it easier to use the volume, and it's perfectly acceptable and very easy. And also applies to all of the devices. Here you have the spectralis, that's the peripapillary retinal nerve fiber layer, 48 and 69 micrometer, and inter-eye difference 31. Use the TopCon, probably one of the most frequent devices available around the world. Here you have at follow-up, again, the fundus photograph. If you then look at the total thickness, this is 57, 79. So the values are now different to the Heidelberg, and the inter-eye percentage difference is really clearly above the 5% for the PRNFL. There's also the Optos. It's a device which gives you the large field, and that is useful for finding some small peripheral pathology, which in her case is not relevant to the optic neuritis, and that is the left eye. So you have situations where you can look in the periphery with these devices. To summarize, in her case, we do have scenario C, the most complex one, because it's binocular. And in that scenario, you're required to have 2 paraclinical tests, one of which must be MRI. In her, we have the MRI. It is abnormal for the flare, but not for the contrast. Why is that? Because in her, the optic neuritis was very anterior. It all happened in the optic disc in the retina at onset. And generally speaking, MRI does not pick that up, except if you have very good sequence and very, very trained people. And I will come back to that. So just remember, in prelaminar optic neuritis, which is very anterior, the MRI may miss the contrast enhancement. And in her case, it was post-vaccination optic neuritis. With that, I do come into the anterior compartment, and to make it simple, I call it Dr. Brain for the neurologist amongst us, and Dr. Eye for the ophthalmologists. And there is no doubt that the neurologists are very comfortable in the brain and spinal cord. And we do refer in our criteria that if we speak about MOG antibody disease, then David's disease, pneumonitis optica, and multiple sclerosis, it clearly says this goes with the published criteria. So what Professor Montalban said is how it is done for MS. We don't do anything different. If you then meet the optic nerve proper, or in the previous case, anterior optic neuritis, which is prelaminar, then remember that the interaction with the eye doctors is very, very relevant. And this is the one condition I pick out, primary progressive optic neuritis, because I think this is something new for you to hear. It was defined similar to how we define primary progressive. Multiple sclerosis, you need to demonstrate progression over more than 1 year. In this case, atrophy. And I speak to one lady I've seen now 3 years ago the first time. She comes from a different London hospital, a very good multiple sclerosis center. And they were surprised because whilst being on dimethyl fumarate and the MRI being entirely stable, she noticed that her vision got worse. So they asked me to see her, and in 2022, when I saw the first time, vision was reduced to 6/9 in the right eye and 6/24 in the left eye. In that very year, where you see the first OCT here for the right and left eye, I saw her after 3 months, repeated the OCT, and there was a small increase of atrophy. So I saw her back after 1 year. You can see how the atrophy progresses. Vision also continues to worsen. And when I saw it towards the end of last year, then you can see some further atrophy in both eyes and further worsening of vision. And all of that without any evidence for inflammatory disease activity on the MRI. And I think probably primary progressive optic neuritis is the most neatest model for studying the concept of PIRA. With all these tests, you have to measure it very, very accurately. With that, I come to the fifth and the last case in my talk. It's a 54-year-old woman who had pain in the right eye, worsening on eye movements. 4 days later, vision decreased to hand movement only. There's a right RPD, which was tested seropositive for MOG. So where are we here? Again, scenario A, the simplest, because there's the pain and the RPD. We only have one test, in that case, the MOG antibodies. Is that already you can combine these two, scenario A with the antibodies, to make a diagnosis of optic neuritis? You don't need MRI or OCT at all if you have access to the antibodies in the right scenario. And that would be classified then as MOG optic neuritis. And this case will allow me to bridge from single case into validation studies, because I followed her up for many years. And in the very first attack, where the right eye was inflamed, very swollen on the OCT, this is the PNFL here, with the MRI, we can observe what happens to the nerve over a 1-year period. Atrophy continues, and you just need to remember, if you see someone after 6 months, it continues for about a year, and then atrophy patterns out and stays stable. And sometimes people get confused by catching the tail end of ongoing atrophy on OCT and forgetting that it does take some time for this entire process to complete. The interesting bit comes in here, in the good eye on the left side, where this nerve becomes inflamed. She gets steroids a bit quicker than before, and you can see less atrophy. An exquisitely steroid responsive condition is really MOG optic neuritis. But just the severity of atrophy chronically and the severity of optic disc edema acutely makes optic neuritis and MOG the perfect condition for these criteria using the retinal asymmetry. This is a study by Julia Wolpe from Switzerland, who looked at specificity and sensitivity of the inter-eye percentage difference and found it to be almost perfect. An area under the curve of 0.99 these days is something you typically see with artificial intelligence, but rarely with such a simple metric. But as I say, it is just made for it. Here's his paper free for download. I talk you a bit more through the group because they were matched in numbers, in age, in gender. So there were no biases here. And if you look at the different metrics, it really is the percentage difference which stands out as the most important one, but they all are significant. It is a good moment to also reflect on the difference between unilateral and bilateral pathology. And very much to my surprise, bilateral MOG-ON is also something we can pick up well. Here you see the raw data, unilateral cases as dark dots, the open circle, bilateral cases for the different metrics, absolute difference and percentage difference. And if you compare all these raw curves, the percentage difference performs best also in the binocular cases. And you can see the sensitivity and specificity are not quite as good because some of these cases don't have so much difference. But overall, it is still impressive what these metrics can do. Sensitivity and specificity throughout are very good. If you look at unilateral cases, this is over 99%. Same for aquaporin 4 for pneumonitis optica. This is a mix of unilateral and bilateral cases published by Frederick Oertel. And again, the area under the curve is very, very good. The abstract details all sensitive and specificity levels. And if we statistically contrast the absolute difference, a micrometer is the percentage difference outperforms absolute difference on every level, statistically significant. And with that, I come back to the case where I mentioned that we cannot see in very preliminary optic neuritis contrast enhancement. This is one spectacular study from our colleagues in the US, Valerie Buss and Nancy Newman. They absolutely know their stuff. And they looked at probably most difficult cohort because they selected 150 patients with acute and chronic optic neuritis who already show on MRI a signal change. But they had different pathologies, infiltrative and ischemic and all so forth. And they did find of the entire cohort, 4 patients did not meet the diagnostic criteria. These were those which would have been falsely diagnosed as positive because of an MRI finding. And what they show here is something you won't frequently see, except if you come from a top center like this US center. This is enhancement of contrast of the optic disc in a patient who clinically very clearly shows an early ischemic disc. And that is something we didn't think about. In anti-ischemic optic neuropathy, you can get contrast enhancement if you really push the field. And it is something where you just need to speak with your eye doctors. And the atrophy which develops after ischemia is just much more rapid. So if you see this patient after 2 weeks, they will already be pallor. Of course, that's not something we see in optic neuritis. But Valerie makes a point. In this scenario, the MRI can cause a false positive. The second study, even larger, another 100 patients more, total 257, come from our colleagues from France, from Lyon. And they looked in their center also at a very, very select group of optic neuropathies. And there had been one false negative. This was a patient with neurosyphilis. Neurosyphilis is something I now more regularly test in London because syphilis, like tuberculosis, is on the rise, but I understand we don't test everywhere. And the false positive ones, 2 of them were Lebers. This is something which should really be taken out by genetic testing. And the 2 infiltrative cases were those where there was a true false positive, which still leaves with 2 out of 257 patients a specificity of 99.3%, which I think is acceptable for a first round of such criteria. With this, I summarize my talk. I spoke about practical applications of the ICRON criteria. I introduced you to primary progressive optic neuritis as a potentially very, very useful model for PIRA. We spoke about retinal asymmetry, and to make it simple, just use whatever device you get. Don't stick to just one particular device. Use whatever device you get hold of. Look at whatever values it gives you on the screen. Choose the simplest one and just look at the percentage difference, and you will get it. And then I hope to have convinced you that these optic diagnostic criteria perform very well in terms of diagnostic accuracy. And with that, I do thank you for your attention. Thank you for the invitation too.
Thank you. Thank you, Professor Petzold. I think that was a pre-recorded presentation. So we have a question and answer session. I think I'm told that we are running behind schedule, so we'll allow just one question from the audience, please.
Hello, Letizia Leocani. Congratulations for your excellent talk. I have a question about the steroid treatment in acute optic neuritis, that the optic neuritis treatment trial did not show a difference in the final outcome, but actually people were allowed 8 days before the start of the steroid treatment. So would you speculate that early steroid treatment would make a difference? So we need a sub-analysis. Yeah. I'm not sure if you have it.
No, that's an excellent question. So again, with the ONTT, like you said, they were allowed to have treatment within 8 days, and actually the majority kind of shifted toward the end. We have looked at the raw data of the ONTT and actually did not find a significant difference in those treated early versus late. But again, the majority of the patients were a little bit shifted toward a later stage. Again, just like as we know with any kind of clinical trial, it's hard to kind of get people in within a day or two. So again, probably early hyperacute treatment may work, but again, it's hard to do that for that very first attack. The other thing about the ONTT is we actually had about a third of the blood still remaining, and we checked to see how many patients were OCA4 positive and MOG positive. None were OCA4 positive, and only 3 patients were MOG positive. And so the ONTT provides very good guidance on MS-related optic neuritis and idiopathic optic neuritis, but not so much for MOGAD and NMO, which we think early steroids definitely leads to better outcomes. So I know a little bit of a long answer, but bottom line is early steroids definitely probably for MOGAD and NMOSD. For MS, I think if you were to catch it in that hyperacute stage, it would lead to better outcomes. But at least the ONTT didn't necessarily pan out that way.
Thank you, John. Thank you for staying on and answering the questions. And I think that brings us to the end of Symposium 5.
Our next symposium is Hot Topics in Multiple Sclerosis. The speaker is Prof Gavin Giovannoni. He is Professor of Neurology in Bilsard Institute, Faculty of Medicine and Dentistry, Queen Mary University, London, board member of European Charcot Foundation. His interest in multiple sclerosis, inflammatory disorders of the central nervous system, and optimizing multiple sclerosis disease-modifying therapies. His research focus mainly on role of Epstein-Barr virus as a cause of MS, and strategies for prevent MS, MS-related neurodegeneration, and development of MS therapies. He is talking to you on Epstein-Barr virus and multiple sclerosis. Over to you, Prof. Gavin.
Thank you for inviting me to give you this talk. I'm hoping to, well, I'm surprised it's still a hot topic because EBV and MS has been around for 30 years now. And the good thing is getting traction, and there are some trials addressing the hypothesis that EBV causes MS. Some disclosures, nothing really that relevant to this because we haven't started trials yet. So just to say to you that to prove a infectious agent causes disease doesn't happen overnight. There's a whole causation theory around how you prove causation. And probably the most well-accepted criteria for causation are the Bradford-Hill criteria. So Austin Bradford-Hill was a statistician who worked with Richard Dole, and they were the two, one statistician, one epidemiologist, who proved the link between cigarette smoking and lung cancer. They put their first publication out in 1951. Their main publication came out in 1955, and it took until 1997 for the tobacco industry to capitulate. So it took about 50 years, just shy of 50 years, for the community to accept causation. And after proving that cigarette smoking caused lung cancer, Bradford-Hill put together a series of criteria that need to be fulfilled to prove that EBV causes multiple sclerosis, say. I've been through this over many, many decades, and I'm pretty convinced we can fulfill 8 of the 9 criteria for Epstein-Barr virus. What we do need still is experimental evidence, and I'm going to discuss some of the strategies today. So this process is not a light switch moment. It takes years to prove causation. And the other thing that happens from a psychological perspective is that the adoption of an idea or a concept or a fact or a meme, if you want to call it that, does also require what they call a diffusion curve. So this is Everett Rogers' classic diffusion curve, where you may get somebody, an innovator who comes forward. So the first person, actually, in my opinion, who put forward the theory that EBV causes MS was a guy called Sven Haar. He was the basic scientist working in Aarhus in Denmark. I heard him talk on this concept in 1999, and I think he was the first person who was pretty adamant that EBV was the cause of MS. So let's say he was the innovator. Then Alberto Scherer came about 5 years later, and then a few of us else came. So there were a few innovators making this claim probably 25 years ago. Then we got some early adopters, and then once you get majority adopters, you get a lot of people accepting this, and finally you get the laggards. And I suspect we are somewhere near the tipping point at the moment, because you can't go to an MS meeting without hearing EBV on the agenda now. So I think we're beginning to move towards this part of the curve, but I suspect we'll need more evidence to convince the majority that Epstein-Barr virus is the cause of MS. So I think the epidemiology is quite convincing, and the one thing that I would like to put forward as being the most important study is the meta-analysis of published papers by Alberto Scherer's group in Harvard that showed that if you do not have Epstein-Barr virus, in other words, if you are EBV seronegative, okay, so this was in close to 2,000 cases with MS and 2,300 cases, control cases, the odds ratio was close to 0. So what's this saying to you is that people who are EBV seronegative, who do not have the virus, are protected from getting multiple sclerosis. We repeated this analysis and added many more studies to the meta-analysis, and we showed exactly the same thing. But what was really important, we pulled out the 3 studies where the gold standard, which is immunofluorescence microscopy against the Ebner complex. And so this is the gold standard serological test to prove you don't have MS. And when you actually just look at the 3 studies, there was 0 cases. Okay, and the reason why I'm saying this is because the current serological testing for MS is not 100% sensitive and specific, obviously. But this actually just confirms the Alberto Scherer's original publication that seronegative people do not get multiple sclerosis. So that's a really important factor. Now, everybody quotes the Canadian pediatric study showing you that when they looked at the pediatric MS patients, only 83% were EBV positive. Well, there has been a recent publication that's come out in Annals of Neurology showing you that when they looked at those seronegative pediatric MS patients, they didn't have MS, they had MOGAD. So even in the pediatric population, this rule holds that if you have a syndrome that looks like pediatric MS and you're EBV negative, you're likely not to have MS and likely to have one of the MS mimics like MOGAD. So I think this is a really robust finding, and it drives the rationale for doing an Epstein-Barr virus vaccine. So this paper is what triggered the current interest. This is Alberto Sherry's group using the US military serum bank. So everybody in the US military has a medical examination and has serum blood test done. And actually the banking was started in the late 1990s to screen people for HIV, to be honest with you. And these people will be coming back every 2 or 3 years, being rebled, retested, and their serum went into a serum bank. So there's over 12 million people in this serum bank. And what they showed was that people who were seronegative at baseline and then went on to develop MS, except for one patient, almost 100% seroconverted before developing or being diagnosed with MS. And with CMV, there was no difference. So this is actually a very compelling argument. It's one of the criteria that there has to be a temporal sequence. In other words, you have to be exposed to the environmental agent before you develop the disease. And so with MS, you have to get EBV before you get multiple sclerosis. They also showed that in these people who developed, who became EBV positive before their diagnosis, there was a neurofilament spike. In other words, they could detect higher levels of neurofilament in the peripheral blood, indicating that there was some neuropathology happening prior to the clinical presentation, CIS or diagnosis of MS, which is another compelling reason that the endophenotype, which is raised neurofilament levels, was happening after the exposure to the virus, but before diagnosis. So this is the comment that's made. EBV is necessary. In other words, you have to have Epstein-Barr virus, but it's not sufficient for someone to develop MS. You need other factors. And so I put forward this domino model. You can use any model in your life, but all it says, it just puts up all the risk factors. And the important thing is that Epstein-Barr virus is really, really pivotal. And if you remove Epstein-Barr, in other words, you have a vaccine that stops you getting infectious, you should stop the cascade that leads to, or the causal cascade that leads to multiple sclerosis. And that's the theory. And the good news is there's lots of activity in the vaccine space. And to be honest with you, it's impossible or virtually impossible for academic university research departments now to develop and produce a vaccine. In the past, it was possible. But with the current regulatory environment and the costs of doing trials and producing vaccines, we have to rely on big pharmaceutical companies to do it. And the big pharmaceutical companies are all coming on board. And Moderna is very far ahead with their 2 vaccines. To be fair, Jeff Cohen at the NIH has been working on vaccines for several years, and these are in some of them are in phase 2. Hopefully those will go through to pharmaceuticals, but all the big pharma companies are getting involved, which is exciting. So we are, I think, going to have a vaccine. We already had a vaccine. We had a GP350 vaccine tested in MS. It was non-sterilizing. In other words, it stopped people getting infectious mono, the symptomatic phase of the disease, but it not stopped them getting wild-type infection. So GSK, who had the vaccine at the time, stopped developing it, which I think was a sad day, because they didn't understand that maybe just reducing the incidence of infectious mono may be sufficient. Anyway, we know that a vaccine will work in terms of preventing IM, and hopefully we'll get these phase 3 trials done in the next 5 to 7 years. That's how long it takes. And then if it can get adopted by governments, health departments, and implemented at a population level, we'll then see a reduction in MS incidence after that. One of the things we had worked on about a decade ago is, could we do these vaccine trials in terms of MS prevention in high-risk populations, people who are at high risk of getting MS? And to be honest with you, we've come to the conclusion that it's difficult, because most people a large proportion of the population seroconvert very early in childhood, and therefore you'd have to start this vaccine in infants. And as you know, MS only emerges in the late 20s, early 30s. So the study would have to be a 30, 40-year study, and there's just not enough patients, to be honest with you, to do that. So I think targeting a high-risk MS population, even if it's children or siblings of people with MS, is going to be difficult for a rapid answer. So I don't think this is a real starter, to be honest with you. So I actually think the primary indication for an EBV vaccine should be infectious mono. I know that we were taught in medical school, and it's still in medical textbooks, that infectious mono is a benign, self-limiting illness, and it clearly isn't. If you read the literature, you'll see that infectious mono has a morbidity attached to the acute infection. Some people have to be admitted because of upper airway blockade. They get quinsy. They often get hepatitis, hemolytic anemias, etc. So just stopping the acute complications of infectious mono would be reasonable. And then there's this incidence of post-viral fatigue syndrome, and it's quite a significant issue. About 3% of people with chronic fatigue syndrome or myalgic encephalitis, depending which term you use, have had it due to infectious mono. Similarly, if you have to take time off school or university, it impacts your learning. And in the UK, a study done in Edinburgh University showed that a quarter of people who had bad IM at university had to miss the year and restart the following year. So it actually has a big impact on learning. Similarly, in the military, it stops military recruits from training because it causes splenomegaly, and there's a risk of splenic rupture if you do any physical exercise. So the US military has a 8-week ban on exercise. In Britain, it's 12 weeks, and that actually impacts on training in the military. And also it impacts on elite athletes. There's a litany of top athletes having IM that had to stop or can't be competitive for at least a year or two after it. So there is a reason to prevent IM at a population level. And then hopefully post-IM, you'll prevent the downstream consequences in terms of autoimmunity and obviously malignancies. So the current proposal that's been emerging from consensus really is that let's get a vaccine at a population level, and then start international or national registers and collect as many patients as you can. And this is where you'd have vaccinated patients. And I think we should do all comers. And there's a debate about this because having to test who's EBV positive or negative prior to the vaccine is quite a logistic nightmare. So I think we should vaccinate all comers, whether or not they're positive. And obviously there will be people who will be resistant to vaccinations, particularly in the current era, and they will act as controls. And then you'd follow them up and see what happens over, say, a 10-year follow-up and compare the 3 different groups. Now, you can actually bank Guthrie cards. And so you could go back after the event and do a nested study to see who was EBV positive or negative prior to developing the vaccine. Gary Cutter, a colleague of mine from the United States, MS statistician, has shown that you would need about, between 210 and 300,000, depending on what power, EBV negatives, if you want to focus on the EBV negative population. So this will be an incredibly large study. And so for that, you probably need to follow up several million people. And this is why I think an EBV vaccine MS prevention study using this population design after the vaccine's been licensed for IM is going to have to be an international effort. I think those kind of numbers can be done in large countries, but I suspect this is going to have to be done across multiple countries. And this is one of the reasons why this is UK data. This is work we did, just showing you that in a serum bank in the country, we're looking at children and adults. By the time people are in the bracket where we think this vaccine will be acceptable, we don't think the vaccine as a new vaccine will be acceptable to the general public in infants. So what we tend to then do is do it in adolescents at the same time when people have the HPV vaccine. And you can see in that period where we would use the HPV vaccine, which is 12 or 13 years of age, already in the UK, about 80% of the population is seroconverted. It's much more common for females than males. The reason is females mature earlier and they start kissing. And as you know, this virus is spread by saliva. And so this gap between females and males is well known across the world. So even if you start vaccinating when the HPV, you can see that, and let's assume it's 70%, because this is a wide gap at 70%, only about a third of the patients will be EBV negative. We really would have missed the other 2/3 that are already seroconverted. Now, there's also this debate about sterilizing, non-sterilizing. I don't think it's important, my personal opinion, because I'd be surprised if the vaccines are sterilizing, in other words, preventing wild-type infection. And the reason I say that is because the herpes viruses are large DNA viruses, very complex biology, and it's unlikely we're going to be able to prevent everybody getting wild-type infection. And I don't know if it's, we could argue whether this is necessary, but I think just preventing IM may be important. And as you're probably aware now, there's a whole immunological story developing in people who are at risk or have MS, showing you that the immune response to the EBV is dysregulated and they have difficulty controlling the virus. So giving a vaccine to somebody who's EBV positive may simply help by boosting the immune response, and they can control the virus in that way. So it may be beneficial even in people who are EBV positive. And the rationale for this is based on the Shingrix vaccine that GSK launched. This is given to adults that already had chickenpox as children, and the idea is to boost immunity to the virus to prevent them from getting shingles, and it works very, very well. You can see that there's a big difference between a placebo versus the vaccine. This is the cumulative incidence of post-herpetic neuralgia, and this is the cumulative incidence of herpes zoster. So there's a big difference, and this vaccine now is being rapidly adopted across the world. And what it implies is that if you do boost immunity in older people who've already been infected, you can actually prevent reactivation of the virus. As you know, herpes viruses have a latent phase, and then they intermittently reactivate to become lytic. And what we're trying to do is prevent lytic infection. And I am of the opinion that it's the latent lytic cycling of Epstein-Barr virus that's driving multiple sclerosis. So a vaccine may work as an immunotherapy. Now, how does EBV cause MS? I don't know. But what I do know is that having IM is a risk factor. So not everybody who gets Epstein-Barr virus gets IM. We think it's probably in the region of about 20 to 30%. And obviously, if you haven't been exposed in early childhood and you get into adolescence and you're EBV negative, it's more common to get IM. Now, the risk odds ratio of getting MS if you have IM is not that great. It's about 2.2. Don't worry about that because this is a common exposure. So when you get a rare disease like multiple sclerosis, as a consequence of a common exposure, the odds ratios tend to be low. Okay. When you have a rare exposure, for example, I'll give you an example like asbestosis causing mesothelioma, asbestos exposure. So asbestos exposure is quite uncommon, and mesothelioma is very rare. When you get those two, the odds ratios are incredibly high. And with mesothelioma and asbestos, the odds ratios are the highest ever reported. They're close to 200. 196, if I remember correctly. So that tells you, so I don't think we should worry about the odds ratios being low. It could still be causal. Anyway, this is a summary of a paper that I've already produced, and it's quite complicated, but all it tells you is that there are two theories that are competing. So the immunologists will tell you that EBV works as a stimulus to the immune system, so it by molecular mimicry, and it's a hit and run event. So once you trigger autoimmunity, the virus is irrelevant. On the other side, there's a group of us that think that the virus is actually driving the disease, and this is called the driver hypothesis. So the virus not only triggers the disease, but keeps driving the disease, and we think this is due to direct infection, either within the central nervous system or in the periphery, and that's driving autoimmunity in the periphery. And if this is correct, then targeting the virus with therapies, be it antiviral therapies or immunotherapies, will work as a treatment for MS. Obviously, if it's a hit and run, targeting EBV after the event is going to make no difference to the disease. So there's these two competing. And I think the immunological data is definitely tilting the evidence towards the driver hypothesis. Obviously, regardless of those two hypotheses, if you go upstream of them and you prevent primary EBV infection with a vaccine, you can prevent both of them. So this is one of the drivers for the testing an EBV vaccine. Now, because infectious mono is such an important risk factor, the question is, if you treat infectious mono, can you prevent MS? And that's a hypothesis that I'm spending the rest of my academic career trying to sort out. I'm personally wanting to develop a treatment for IM. There are no licensed therapies for IM, but there are some really good candidates for repurposing, and there's some new candidates that are still in development. And my analogy is streptococcal infection causing rheumatic fever. So I don't know how common rheumatic fever is in Sri Lanka, but I trained in South Africa where we had a dual healthcare system. But in the apartheid South Africa, there was a very high incidence of rheumatic fever simply because of poor healthcare systems. And as you know, rheumatic fever is a thing of the past in high-income countries. That's if you treat streptococcal infection rapidly and appropriately with antibiotics, you prevent the downstream autoimmunity. So as you know, streptococci, group A strep, that's strep pyogenes, is probably the most potent trigger of autoimmunity of any infectious agent we know. So we all like to think of rheumatic fever, but there's Sydenham's chorea, there's glomerulonephritis, there's arthritis, there's a vasculitic syndrome like Kawasaki's disease that's linked to streptococcal infection. So there's a whole cluster of autoimmune diseases that happen as a consequence of streptococcal infection. I personally think streptococcal triggers that by superantigen-driven autoimmunity rather than pure molecular mimicry, but there's evidence for both. But the point I want to make out is we as a medical community did not do randomized controlled trials of antibiotics to show that penicillin, for example, prevented rheumatic fever. It just emerged from registries, data. And so this is now streptococcal infection. This is an old study from Canada, just showing you that the incidence of streptococcal infection was unaltered by antibiotics, but the incidence of rheumatic fever dropped dramatically. And I'm hoping that same thing will happen with IM. If we can develop a therapy for IM, we'll see the same thing, the incidence of MS drop dramatically. So this is my model. And there's also a case for antivirals, just to say to you that if EBV is driving the disease via lytic-lated in psych, we should be targeting it at several places. We could be targeting the B cell level, and if it does infect other cells, we could be targeting the central nervous system. So there is a case for antivirals. What we do know is that in people with established multiple sclerosis, they have the immunological fingerprint, that they're not controlling the virus. So when you're not controlling the virus and you getting reactivation of the virus, every time it reactivates, it boosts the immune response to control the virus. So you see that at an antibody level, what you find is that the repertoire of antibodies to epitopes widens. So you can see how wide the MS population is in terms of its antibody responses. It goes way beyond the immunodominant population, and starts targeting what we call non-immunodominant epitopes. This is looking at epitopes in EBNA1. And so that widened antibody response is telling us that the virus is probably active, driving a widening antibody repertoire. And the same thing has been shown by Nicholas Schwab's group with the T cell repertoire, is that it gets much deeper and wider, and it also covers both latent and lytic. So in healthy controls, you get very little T cell responses to lytic. It's mainly to latent antigens, which is not surprising because latent antigens are produced all the time, whereas lytic is only produced when the virus becomes active. So people with multiple sclerosis and people at risk of multiple sclerosis, have a widened and much deeper T cell repertoire. So this is really, really interesting. And as I've mentioned to you, this is probably an immunological fingerprint or indication that the virus is active. Then there's work from Michael Pender, and this hasn't really been reproduced, which I find surprising, but it should be reproduced, just showing you that people with multiple sclerosis, particularly more advanced MS, these are progressive patients, have an altered immune response to the virus. In other words, they tend to have an immunosenescent fingerprint. In other words, their cytotoxic CD8 T cell responses are not good enough to control the virus. And this is one of the reasons why Michael Pender and his colleagues developed, at the time, autologous T cell therapy to try and correct this. And later on, Atara Bio as a company went on to do allogeneic cytotoxic T lymphocyte response treatments as well, which failed. So, by the way, this phenotype we see from an immunological perspective of an exhausted T cell response is not unique to Epstein-Barr virus, say in MS, but it also occurs in other chronic viral infections, be it hepatitis B, HIV, SARS-CoV-2. We see it with JC virus in people who get PML. So this is a immunological fingerprint of chronic viral infections when the virus drives the immune system to exhaustion as the immune system can't control the virus. And hopefully, if we treat MS by targeting EBV properly, this immunological fingerprint will reverse. So to conclude then, I would just say that EBV is the cause of multiple sclerosis. I think in my head, it's overwhelming the evidence. I can't think of how it can't be the cause. And I think if we can prevent people getting Epstein-Barr virus with a prophylactic program, we will prevent it. And then I'm also of the opinion that if we go downstream and we start targeting the virus either by using antivirals or immunotherapies to boost immune responses to the virus to control it, or we use small molecule antivirals and control the infection, I think personally we're probably going to have to try and target the virus in both the latent and the lytic. If we only target lytic, then we won't get rid of the pool. Or we can use established therapies. So I haven't had time to go through this, but the new class of treatment being developed, BTKI, Bruton tyrosine kinase inhibitors, they are effective against EBV because Epstein-Barr viruses uses BTK as a pro-survival signal. Anti-CD20 therapies are known to be anti-EBV, and similarly anti-CD19 and CAR T cells. So some of our existing MS therapies probably work via Epstein-Barr virus mechanisms. So I think the playing field is wide, and I think we need to be investigating all strategies, not just one strategy. So it's all quite exciting times. Unfortunately, the big pharmaceutical companies that are developing therapies are not really keen to show their drugs work via EBV mechanisms, because that will lower the entry level for competing companies coming in with antivirals. But anyway, I think regardless of the current playing field, I think we're going to start seeing new antiviral therapies being tested as treatments for multiple sclerosis. Just to say to you, Moderna, for example, is just starting an international phase 2 trial of their therapeutic vaccine. This is an immunotherapy to try and boost immune responses to control the virus. So there's activity starting in the field. I'd like to acknowledge the people who've helped me and funded me, and I'll stop there and take questions. Thank you very much.
Thank you, Prof, for that excellent and informative lecture on Epstein-Barr virus and multiple sclerosis. And we'll move to the next lecture.
Okay, we'll move on to the next talk. It's by What's New in Multiple Sclerosis by Prof Ralf Gold from Germany. He's the chair of Department of Neurology, University of Bochum, Germany, and he was the previous head of the Institute Multiple Sclerosis Research, University of Göttingen, and he has done contributed many research and academic activities related to multiple sclerosis. Over to you, Prof. Ralf Gold.
Yeah, good morning or good afternoon from Germany. Ready to share the screen now. Thank you for the invite. Seems to be a very interesting and wonderful meeting, and was a pleasure to hear Gavin already talk. And now my subject of talking is to report on new findings in MS therapy. So I move on my slides. This is my research report, support and honoraria, which I received. Just want to make one step back and show you a finding which I found very exciting, that MS seems to be transmitted via ancient tribes, which needed a very strong anti-infectious immune system to survive. And this is findings from the Fugger group from Oxford. And they looked for ancient DNA, and 5,000 years ago, they found the genes which made the immune system strong in the Yamnayas, which was somewhere in Central Asia, and they migrated to Middle Europe, to Northern Europe, where we now have quite a lot of MS, and 70% of these genes are still preserved in our MS patients. So the need for a strong immune system was more or less genetically transmitted to our new decades and our new lifestyles, where we don't need the immune system any longer, and now we get MS instead of this. So with the new therapies, please keep in mind that, again, MS at the beginning obviously seems to remit. There's some plasticity, but then finally, after a long term, an MS also gets sitting and inflammation has transmigrated into the CNS, and then you have the neuronal damage, which is increasing, and also novel therapies, which may now come in the next years. They also need to be applied quite early, because if it's too late, then the neuronal damage seems to be irreversible. And in a nice review with many authors, Tanya Kuhlmann has here summarized all the putative elements which can contribute to neuronal damage, which can be investigated, for example, looking for neurofilament light chains, for GFAP light chains, and which may also contribute to PIRA, the progression independent of relapse activity, which may drive the disability in MS. So having said this, we now come to BTK, proton tyrosine kinase. Proton was a former North American Army doctor, and he found this enzyme in kids which had a genetic problem and couldn't activate their B cells and had immunoglobulin deficiency. And as you can see here, the B cell function transmits signals from the immunoglobulins, which are the B cell receptors, downstream to activation of the cell via BTK. The same holds true via microglial activation, and here also BTK is needed. So saying it in other words, the basic idea of the BTKs is you can reach both sedentary microglia macrophages in the brain, in the inflamed central nervous system, especially in chronic states of MS. And at the same time, there are also B cells which may trigger inflammation, complement-mediated damage, and other things in the inflamed CNS. And you can also more or less silence the B cells in the inflamed nervous system. And the first published study, and I show it just for completeness, was expected with great optimism, and was unfortunately completely negative. This was evobrutinib. I think it will be published in Lancet Neurology. And this study, guided by Javier Montalban, compared evobrutinib with the usual combat drug nowadays, teriflunomide, phase 3 study, evolution 1, evolution 2. You see altogether it's more than 2,300 patients. And you see the relapse rate, the primary endpoint. This was in relapsing forms. And evobrutinib and teriflunomide didn't really show any difference. And when you look at the T1 GET lesions and new or enlarging T2 lesions, it was quite the same, meaning finally that evobrutinib didn't do the job. And there was a lot of speculation, of course, also a lot of disappointment. And probably it has to do with the blood-brain barrier permeability. And if this is true, then there were greater expectations on tolebrutinib, which obviously has a better pass through the blood-brain barrier. There are some studies in primates which were done. And here it was the SPMS study. As all of us are aware, there is not really approved medication for the SPMS and tolebrutinib versus placebo in patients with advanced SPMS already, which didn't have any relapses any longer. And this study was named the Hercules trial, was presented at ECTRIMS. You have the SLCTRIMS in Sri Lanka. So this was 4 months before this in October at Copenhagen, also expected with great attention. And this is a primary endpoint, the 6 months confirmed disability progression. And as you can see, this is the placebo group, the gray shaded lines, and the tolebrutinib were the red ones. And if you look at the risk reduction, you come to a 31% risk reduction. And this is absolutely significant. So the disability accumulation in a SPMS population, which is no longer relapsing, so it's around EDSS 5.5 to 6, already quite advanced in MS. And this was significant. Very good achievement. And vice versa, there are more and more studies in progressive populations which also look at the confirmed disability improvement. And here you can see that also under tolebrutinib, you have a confirmed disability improvement of 10% as compared to 5% with placebo, also significant. The reason, of course, it's not a pro-regenerative drug. The reason is that if the inflammation is stopped in the CNS, there may be some intrinsic activity for regeneration. This is not pro-regenerative, just stopping the inflammation. At the same time, the same sponsor company, which was Sanofi, they had a study in relapsing forms of MS. They called it Gemini. And the Gemini was a comparator with teriflunomide. All companies like teriflunomide nowadays as an active comparator. And it was negative for the relapse rate, Gemini. But if you now look in Gemini 1 and 2, again, 2,000 patients, the time to 3 months confirmed disability worsening. And again, you see that you get around a 30% risk reduction, exactly 27%. And again, tolebrutinib is superior, although it didn't have any significant effect on the relapse activity. So I think it's with great expectations that we are now expecting. And the third one, there is a Petzold study. So after Hercules Gemini, they have a third study in PPMS running. For the patient's sake, I would cross the fingers that this is also positive, expected around fall of this year. And to my knowledge, currently, both in Northern America, that's always faster than in Europe, the FDA checks whether there's a fast track approval, and the EMA in Germany, in Europe, the EMA in Europe now sitting at the Netherlands and Amsterdam, is probably a little bit slower. So maybe the decision of the EMA will be late summer. So there's new hope for progressive forms of MS, and the BTK inhibition with an agent which causes blood-brain barrier effectively is really significant. And there are, of course, more drugs of the BTK family on the run. There's fenebrutinib, for example, from Roche, and there's another one from Novartis. So let's wait for these outcomes. Well, at the same time, there was a revival of a drug which was studied at the beginning of this century. I remember being 20 years younger at that time. This was the inhibition of the CD40 and CD40 ligand interaction. And there's some background that this interaction seems to be of importance in MS because CD40 ligands are also on thrombocytes, and this interaction also releases soluble thrombocyte mediators in active MS and also in PPMS. And the point is that the pro-inflammatory T cell stands in the center of the immature dendritic cells. So we get back to the innate immune system of the B cells, the adaptive immune system, and again, the innate with the macrophages. And if you block this, then you have a good choice and a good chance to silence the T cell activation, maybe also in more progressive phases of MS. The historical background is that the antibodies which were used 20 years ago, they were complete antibodies having the FC part. And via the FC part and cross-linking of thrombocytes, the CD40 ligand is also thrombocytes, there was some thrombosis finally mounting into pulmonary embolism. And therefore, this is a FAB2 fragment. So clearly saying the same target, but new molecular engineering of the antibody, no longer thrombosis. There's no data of enhanced thrombosis in the study. And let's look at this data from Flannagan, which were published in the New England Journal late in the last year. I have the source on the next slide. And you can see now they presented it before without the dosage. And now we know that there was a subcutaneous group with 300 mg every 4 weeks, and there was a frexalimab group. Frexalimab is the name of the anti-CD40 ligand antibody with 1200 mg, so fourfold higher. And they looked at the relapse activity, and you can see as compared with the pooled placebo in this phase 2 study lasting for 12 weeks, the number of new gadolinium-enhancing lesions was reduced by around 90%, highly significant, and the higher dosage was superior. You may bring the question, do we really need this in modern times where we have all the anti-CD20s and also VLA4 inhibition is now generic and comes more and more popular. So clearly saying, I see the chance of this, that you can hit the innate immune system, you can silence interaction between T lymphocytes and the innate immune system, and maybe, and this is currently a running study, this is even tested in progressive forms of multiple sclerosis, PPMS, and this, of course, would be a great chance if it could be shown that the contribution of T cells is also present in progressive forms. And this is just showing you the side effects. And this is, as I showed you, the source, New England Journal, end of last year by Patrick Flannagan, France. And you can see the adverse effects. You see COVID infection, you see headaches. And there was not a significant number of adverse effects in this phase 2 study, but we are waiting for more results. So getting to the end of my talk, there is a new kid on the block, we would say, and this anti-CD20 monoclonal antibodies. And all this was designed to be a glycoengineering. They call it ublituximab. The binding sites are a little bit broader, but mostly overlapping with ocrelizumab and ofatumumab. And really the great difference is that biochemically via glycoengineering, the oligosaccharides, the fructose remnants at the FC part, they were removed. And the hypothesis is when you remove fructose, then in the antibody dependent, also, of course, in the cellular dependent cytolysis in the CDZ, the NK cells can easier tackle to the FC part and thus remove the B cell targets. So it postulates a deeper depletion of B cells and via that a maybe prolonged activity. So let's look at the results of the studies. They were 2 studies which were face-to-face, and these studies were also published in the New England Journal, and also around 1,200 patients published by Larry Steinman as a single paper in the New England Journal 2 years ago. And there was ublituximab in a double-blind, double-dummy study with teriflunomide. So already noted, teriflunomide is unique when you do a modern study, randomized 1-to-1. So they either got ublituximab plus a sham placebo, or they got teriflunomide plus a sham infusion, so that they couldn't distinguish it. And after 24 weeks, there was a extension study where all patients were offered oblituximab. And you can see in these ultimate studies something which is similar what we see from other CD20s which have compared with teriflunomide. It's around 49 to 59% relapse reduction. And with regard to the gadolinium-enhancing lesions, it's more than 95% different. So saying it's greatly superior. And I think it's also reassuring to look what I already mentioned with tolebrutinib, the CDI, the confirmed disability improvement. And here within 12 weeks, you have a 12%. Within 24-week interval, you have a 99.6% disability improvement. So again, indicating that there's a deep shutdown of inflammation. And in turn, there's a possibility to regenerate also in the adult immune system. This is not active adult regeneration. Quite saying this, it's not pro-regenerative, but the postulate is deeper depletion. So what I personally have seen from this, we have around, it's approved in Germany and Europe since February last year. So we have around 1 year experience, 80 patients. And at the beginning, I thought, well, let's challenge this. And I took a very sad case of a 37-year-old male patient, wheelchair bound. He developed optic neuritis and got highly active immunotherapy outside of my department, progressed to be wheelchair bound and only able to transfer EDSS 7.5 with help. And when he came to Bochum, we got him off-label medication with Rituxan. Then he got Ocrevus. He got some allergic reaction, although this is very rare. This was a very severe rash. I didn't dare to do it again, so we continued CD20 again to stabilize him. He was unable to walk since around 2018. And then I offered him, well, I can't promise you, I was honest, there is a new anti-CD20, which theoretically may be superior, and this is oblituximab, because he also had a deterioration, a progression of ataxia, of control of his body, and also the weakness was progressing. So some days later, the physiotherapist called me. He was for some days on the ward. He also needed an improvement of antispastic treatment. And here you see the video. You see a physiotherapist before and a physiotherapist behind him. And I mean, this is, of course, a walker, advanced physiotherapy walker here on the ward, on the floor of the ward. But at least he was able now to walk around 15 meters with only a little help. And he hasn't been able to do so in the last 6 years or so. So let's wait for more real life data. And with this, I come to my conclusions. There's a lot of further neuroprotective work ongoing. And as Professor Giovannoni already mentioned, also some studies are ongoing to challenge this. The novel medications in MS possibly affects also in primary progressive forms of MS. Some BTKs are running, as I told you. So let's wait for more data on this. And I summarize, I didn't talk a lot about this progression independent of relapse activity PIRA. It's not well understood. It's maybe smoldering lesions. It may be iron rim lesions. I showed you the BTK, which was successful. This was a tolebrutinib. It was not the evolution studies, but it was the tolebrutinib studies. In the Gemini and the Hercules, the Perso is still to be expected. And this, at least to my knowledge, independent primate studies passes the blood-brain barrier. This is, of course, important if you want to hit the culprits of disease progression, the B cells there, and macrophages, microglia, and it was significant. Let's wait and see what it means for everyday's practice in MS. And with the anti-CD40 ligand, all of us are aware that we have this 90% relapse reduction and even higher with monoclonal antibodies on CD20, but here we have an interaction with innate immunity. This is a great hope. And finally, the bioengineered anti-CD20. I showed you, at least in my experience, I showed only one case. I have some similar cases like this, may have some superior properties in a deeper B-cell elimination. We usually also check in the flow cytometry after 6 months. This antibody is given 450 mg every 6 months intravenously. And so far, when the reinfusion was needed, they were still depleted. I think important point is whether the patients are still really depleted when they get their reinfusion, or whether there is already a significant rise of B cells observed in patients after 6 months. This may make a difference between different anti-CD20 therapies. So thank you. It's a pleasure to contribute to this nice meeting, and I'm ready to take questions. Thanks for the invite, and I stop my sharing slides.
Thank you very much, Prof. Gold, for that stimulative talk on latest therapeutic options on multiple sclerosis. I think we can accommodate a couple of questions. As I heard, Prof. Giovannoni also is online with us, so we can entertain a couple of questions.
Oh, maybe it was clear, but I'm of course also open to take other questions on other currently running studies.
This is Peter Hartung. Congratulations to both speakers. As expected, excellent talks. May I ask Gavin, and this may be a kind of old-fashioned question. I remember a fierce discussion between Francesca Aloisi and Hans Lassmann regarding the detectability of EBV in MS brains, and perhaps if one could also focus on maybe a comparison of the expression in acute lesions versus the compartmentalized lesions. I'm aware of Larry's work on determining molecular signatures, but haven't seen much after that. What is your reading, Gavin, as relates the detectability and maybe a differential location of EBV or its proteins in the diseased brain?
Yeah, so I think as you're right, I think the controversy was around the sensitivity and specificity of the in situ hybridization, looking for EBV. However, there has been work done since then using detection using immunohistochemistry, looking for protein expression. And I think there is a small incidence of detecting the virus in people with multiple sclerosis. But again, Hans-Peter, as you probably know, because EBV resides in memory B cells, this just could be a biomarker of the fact that memory B cells traffic into the central nervous system. I think the more compelling data is the T cell receptor and the phenotype of T lymphocytes in this CSF, suggesting that what you see a much higher proportion of affected memory cells, suggesting they've recently seen the virus. So I think from an immunological perspective, it would suggest that there is EBV in the brain. I don't know if that's relevant. I think, because what we do know about using a disease analogy, so you all know about HTLV1 myelopathy. And I think it's pretty accepted now that the HTLV1 is the cause of the myelopathy. And it took a long, long time to detect that virus. And we didn't have to detect the virus from the central nervous system to be part of the proof. It came much, much later. And the detection level of the virus is really, really low. And I think the same thing may be for EBV. The viral loads may be incredibly low in terms of detecting them. Another example, is that the virus may be cleared. So there is an animal model that I think comes closest to MS, and this is the marmoset, the macaque model in Oregon, where these animals come down with a spontaneous encephalitis, and they have to be culled. When you actually kill these animals, they've got a CNS inflammatory disease that looks very similar to MS. Again, the virus was not detected. It's very difficult to detect the virus, which happens to be a gamma herpes virus. It's an EBV of macaques. And the virus is only detected by passage in the brain slices from those animals, and it came on the 5th or 6th passage. So the viral loads can be very low in infection. The one difference would be, and this is a really important observation, is when you stop inflammation-reducing viral loads, like with natalizumab, Tysabri, the two cases where brains of people who have died as a consequence of Tysabri withdrawal, relapse, have both shown very high EBV viral loads in the brain. So I know the in situ work has been controversial, but subsequent to that, I think there is a good immunological evidence and the two Tysabri cases to suggest that EBV viral loads are raised in people with multiple sclerosis.
Thank you very much, Gavin. Sorry, go ahead.
No, that's all. That's fine.
Okay, thank you very much. Could I ask Professor Gold? Hello, Ralf.
Hi, Peter. Hi.
Very nice talk. I was impressed by the patient you showed on ublituximab. I mean, you pointed out the results of the ultimate trials, and if one sort of compares them, which is obviously not exactly appropriate with the Ocrevus trial data, it wouldn't immediately appear that there is a major difference in efficacy. And the company TG claims that, ublituximab has more potency in terms of ADCC. Could you imagine that this or a slightly broader epitope recognition might be responsible, and how can we sort of come close? I mean, this is an important question to differentiate the use of ublituximab versus the standard anti-CD20.
Yeah. Yes, you are right. Thank you. That's a nice question, Peter. But we are in academic situations. We always have to be careful not to be interacting with other maybe commercial claims. So yes, the epitope binding is a little bit broader. I must clearly say I didn't test any immunological reactivity against different epitopes with maybe taking peptides from the CD20 molecule. What we looked at and what I noted briefly is the beginning rise of B cells after 5 to 6 months after the last infusion, and comparing it with a international standard, which is since 6 years ocrelizumab. And it seems to be the case that at least the beginning rise in B cells and the repletion is later in those 80 patients, which I have the overview, then compared with another cohort of Ocrevus patients. And as you definitely know, and I think you are also part of the study team, that for those patients who may need a higher dose of the first approved monoclonal ocrelizumab, Roche is even trying a study which has a 2 to 3-fold higher concentration. They name it Muset, and we are waiting. I think it may be presented this year at AAN, and we are waiting, I think, with great interest for the results of this study, whether the 3-fold higher dosage gets a better long-term depletion of B cells. So meaning this may be a differentiation very careful after the first year of experience from the academic standpoint. But I saw some surprises in patients, just clinical observations when I switched them. Thank you.
Thank you very much, Ralf. All the best.
I think we are going to wind up the session. Thank you very much again, Prof Giovannoni and Professor Gold, for excellent talks and joining us with virtually. Thank you very much.
Bye-bye.
Now we come to the final segment for this year's Congress. Some of our young neurologists are going to present some of their cases very briefly to the international expert panel. So we will start with the first presentation by Dr. Achala Vanasinghe, pediatric neurologist.
Good afternoon, everyone. I'll proceed with the case number 1. This is a 15-year-old boy from Mathura, which is an area well known for the paddy fields. And when this boy presented to our ward, he had a dizziness, vomiting, neck stiffness, double vision and blurring of vision, which started about 24 hours ago, which is an acute presentation. And with that, there was a background history of chronic wound over the leg, and he was having on and off high grade to moderate grade fever over 1 month duration, which did not respond to any of the antibiotics. And these are our clinical findings on presentation. GCS was 14 with neck stiffness, left medial rectus palsy, bilateral upper motor type 7th nerve palsy with ataxic gait, bilateral positive finger nose test, but upper limb and lower limb examination was normal on presentation. No bladder involvement and fundus examination was normal. So we did the baseline investigations. Everything came as normal. Full blood count, CRP, ESR, and the urgent CCT brain was also normal. So with the very first presentation, we started the child on IV cefotaxime, acyclovir and dexamethasone, thinking of a meningoencephalitis. And we performed the lumbar puncture on day 4 of antibiotics and the antivirals, where the report showed polymorph 7, lymphocytes 94, proteins were normal with 42. There was no significant sugar difference. And the EEG showed generalized slowing, which suggested encephalopathy or encephalitis. CSF culture, blood culture became sterile, and CSF viral studies were normal. And while these investigations were going on, and while the child was on antibiotics and the antivirals, fever continued with the high-grade fever spikes. And suddenly on day 12 of the illness, child had an acute deterioration of the GCS and needed intubation. And at this time, as our investigations and all the other cultures became as sterile, but still, as the child has been treated previously with several antibiotics, we changed over the IV cefotaxime to IV meropenem and continued the acyclovir and the dexamethasone. And then the condition was static, and we started investigations for a PUO, including all the rare etiologies, the bacterial and rare viral studies. And on day 25 of this illness, while in the MICU care, child developed focal convulsions. And with that, we went ahead with the MRI brain. And these are our images. This is the very first presentation. Would you like to comment about it? And this did not show contrast enhancement, and it showed diffusion restriction in the involved areas. And these are the other images, the series of images. And with these images, we got the report with the T2 flare high signal intensities involving bilateral deep and subcortical white matter associated with high signal corticospinal tract involvement. Differentials were taken as edemoviral leukoencephalopathy, and we started the child on immune therapy.
initially with the immunoglobulin, but there was no improvement. And while the child was started on the IV methylprednisolone, we got the positive report for a melioidosis, 1 in 640. And with that, the TB screening and all the other the rare organism screening came as negative. So we were in a doubt whether this can be a melioidosis with the neuromyelioidosis, or whether this is a ADEM or other immuno-related condition. And with that, anyway, we, as child showed improvement with the fever and also the clinical GCS improvement, we continued with the steroid IVIG, but the marked improvement was with the Plex, where we did 5 cycles, and following the Plex cycles, fever completely settled, GCS improved back to 10, and we started the child on rehabilitation and tapering dose of the oral prednisolone. And child stayed in the medical care for 6 months and discharged with the clinical conditions of the MRC score 4 with upper limb and lower limb, increased tone, exaggerated reflexes, and upgoing plantar reflex. And activities of daily living gradually improved with the time with the modified Rathkin scale of 3. And then after that, we followed up the child in our clinic over last 2 years duration. There were no clinical relapses, but child continued to have the spasticity and the upper motor symptoms. And we did mock aquaporin for an OCB, but this is few months after the presentation, and it came as negative. Fundal examination and VEP was normal. And these are the images a year later. I have the comparison study of each of these images. Shall I go ahead with that? Yes, sir. Yeah, and actually I'll directly go ahead. And these are the very first images, and the 1 year later and the second year later. In the reporting of the very first 2 images were recorded as there are some new involvement in the images, but after another year everything resolved, and we didn't do anything except for the steroids which were given at the very beginning, and we were only continuing with the rehabilitation. And these are the series of images over the time, and this is with the 2-year gap. And the concerns we have are, is this a case of neuromyelioidosis or post-infectious ADEM? And what is the possibility of this being some other atypical CNS inflammatory or demyelinating disorder? And the initial presentation, we were managing this child as per ADEM. And if this is the child you encounter in your facility, what would you have done differently or better with the immunotherapy for this child?
Well, first of all, thank you very much for so nicely presenting this interesting case. We have very, very few cases of melioidosis in Germany, so I cannot really expertly comment on this. But just one question. There were no extra CNS manifestations like we've seen in Germany, dermatological and arthritic manifestations.
No other.
No. So initially I would have thought, meningoencephalitis of viral origin or ADEM, which obviously is also in the majority associated with a viral infection, and we would have initiated a broad-based antibiotic treatment. Obviously, you couldn't exactly judge the CSF because you had already started antibiotic treatment. And of course, the major differential, in my view, would have been ADEM. And we, under the cover of the antibiotics, would have started high-dose corticosteroids. We usually do pulse therapy for 5-7 days and then taper off. And sometimes if there's no response in ADEM, we then add either IVIG or plasma exchange.
Well, as for the possibility of NMOSD, I don't think I have seen such a almost bilateral lesions involving the brainstem and corticospinal tracts. So I think it's atypical for NMOSD. And in your initial lumbar puncture, you detected some red blood cells?
Yes, it was 200.
Is it not because of traumatic tap?
That we are not sure actually.
Oh. Well, as for the treatment strategy, well, I fully agree with Professor Hans-Peter Hartung. Have you searched for literature showing there was similar distribution of the brain lesions?
Yes. The other question is if this is the severe type of ADEM, the spinal tract, the corticospinal tract involvement and the clinical picture of the spasticity and the disability, like the residual disability is still there. And will that be a part of the severe ADEM, like whether we need, if we have done more during the very first presentation, would that have been prevented? Or whether this can be neuromyelioidosis, which give rise to the tract involvement and also giving rise to that post-infectious damage, which retained as the spasticity.
So if the detection of red blood cells are not due to traumatic tap, it may be possible that that this encephalitis may be kind of hemorrhagic. But did you detect the hemorrhage by T2 star?
No.
No. Okay. Thank
you. Just a comment on this. Actually, we see more myelioidosis than you. So actually, the recovery, what she's telling us, fast recovery with plex, is something that we don't see with myelioidosis. We don't see that with myelioidosis. The recovery is slower than that. So she's reporting a very rapid recovery with plex. So there might be a immune basis to the whole problem, maybe ADEM triggered by infection.
Also, can I ask you, the second MRI looked worse than the first, so it's more likely to be post-infectious ADEM, because I would expect if it's only neuromyelioidosis to improve with the antibiotic treatment than to get worse. Right.
We gave the proper antibiotics. The meropenem proper course was completed for this child, and even with that, the symptoms were continuing. That's why we went ahead with the immune therapy, thinking of the immune involvement. Thank you.
Yeah, the next case will be presented by Dr. Arun Rajaratnam.
Can I have my slides? A very good afternoon, everyone. The second case which I'm going to present today is about a 34-year-old pregnant female with no prior comorbidities. In her 10th week of pregnancy, she first presented to a local clinician with subacute onset painful visual impairment of right side eye. And at that point, she had a visual acuity of 6/12 with color desaturation, a relative afferent pupillary defect, and disc edema. And she had a very good improvement with low-dose dexamethasone given for 2 weeks. However, about like 8 weeks after that, while she was like 20 weeks POA, she presented with a subacute history of fever, headache, confusion, and generalized tonic-clonic convulsions. And at that point, we found that she had right-sided disc edema, a mild one, but there were no examination findings of meningism or focal neurological signs. And she had elevated blood inflammatory markers, and naturally, as we suspected an infective meningoencephalitis and treated appropriately, and she was only given IV dexamethasone for 48 hours. And however, she had a further deterioration of her sensorium, and with high aspiration risk in the subsequent weeks, she required intubation and ventilation. And her cerebrospinal fluid showed a marginally elevated protein, and more importantly, very high levels of polymorphs at 450, 20 lymphocytes, but much of the markers for bacterial and TB screening were negative, so was the HSV screening. And her EEG showed left side focal slowing. Interestingly, her MRI at that point showed a unilateral T2 hyperintensities of the gyri, the cortices, as you can see here. And there was only subtle meningeal enhancement. There were no parenchymal lesions, and there were no diffusion restricting lesions either. The MRI orbit showed subtle T2 hyperintensities of the right side optic nerve, which is acceptable. However, her next 4 weeks in the ICU suit was very stormy because she continued having fever spikes and was in sepsis, as evident by the high inflammatory markers, and the source of the sepsis was a respiratory infection, a severe one, as you can see here. But MRSA was positive. We tried our best to rule out TB, which was tuberculosis, which was ruled out. And with treatment with appropriate antibiotics, there was a response to sepsis. But at around 27 weeks of POA, in the same hospitalization, while she was slowly recovering from the critical illness, she started complaining of subacute new onset painful bilateral visual impairment. And visual acuity, which was about 6/9 in the beginning, was 1/60, and there was bilateral disc edema. And the visual evoked potential was unrecordable. The MRI brain showed an improvement in the brain changes. There was no unilateral cortical high signal intensities, which were noted 4 weeks prior. However, there were some new changes. There was extensive high signal intensities. That's long segment optic neuritis involving the chiasm as well as the tracts. And there are some high signal intensities in the medial thalami as well as a single lesion in the corpus callosum, as you can see. The CSF at this point had clearance of polymorphs and lymphocytes were predominating. And with further tests, we excluded inflammatory causes, autoimmune causes, nutritional causes, and most of the viral infections, which can give rise to a similar picture. And she's pregnant, and we treated her with methylprednisolone just 5 days, but she had only a minimum improvement. We continued with an oral prednisolone tape and azathioprine. We were quite skeptical in starting advanced immunosuppressive modalities such as plasma exchange or biologic, and therefore she was discharged on that with appropriate advice. So she had a live birth at 36 weeks of POA, but unfortunately she self-discontinued her steroids and azathioprine and presented 2 weeks after delivery with a subacute bilateral lower limb weakness, urinary retention, worsening vision without a fever or infective trigger, and a spastic paraparesis with a sensitive level of T6 and a worsening visual acuity to finger counting and optic atrophy. As you can see in this MRI whole spine, there were several longitudinal extensive segments in the cervical-dorsal, as well as the dorsal spine, segments of myelitis, and these were showing ring enhancement and homogeneous enhancement. And in the cross sections, as you can see here, most of them are centrally located, with predominantly more than half of the spinal cord being involved. And most importantly, the conus medullaris was paired. The MRI brain did not show any gyral changes. However, there were new lesions appearing. There were these ovoid-shaped high signal intensities, predominantly in the supratentorial white matter. Some of them are deep, some of them are juxtacortical, some of them are periventricular, and some of the lesions had a corresponding T1 hypointensity, and some of them were also faintly enhancing as well. The orbits continue to show worsening of bilateral optic neuritis with involvement of the chiasm and optic tract. CSF at this point, the proteins was elevated and was acellular. Once again, we excluded an ongoing tuberculosis infection. And we have new investigations here. Melioidosis was negative. Her CSF OCB was about positive at 1 to 3 bands. And serum MOG IgG antibodies, which was done at the flare, at this relapse through a fixed cell-based assay was positive, but the titer was low, 1 in 10. We didn't have facilities to perform CSF MOG IgG antibodies, and aquaporin 4 antibodies were negative. So she was treated with IV methylprednisolone and plasma exchange every 5 alternate day cycles, with which she had a very good improvement of her spastic weakness, but the improvement of the visual acuity was only mild, from finger counting to 260, and the fundi continued to show optic atrophy. And at this junction, we thought of giving her B-cell repletion therapy. We induced her with IV rituximab. In the next following month, when she presented to her second dose of IV rituximab, her visual acuity remained to be 1/60, and she was on this tapering course of prednisolone as azathioprine. And quite fortunately, when we reviewed her the following month as an outpatient, she had an improvement in her visual acuity. And her VEP also showed, which was previously unrecordable, there is tracing with the latencies on bilaterally. It's within normal limits, but there's a discrepancy of 9 milliseconds and amplitude marginally reduced. An optical coherence tomography showed severe thinning of the ganglion cell layer and thinning of the retinal nerve fiber layer as well, with sparing of the nasal quadrants. And however, that improvement did not last long, because at 5 months POA, that's the following month, she presented with a mild worsening of bilateral vision. We took it as a relapse, and we gave her methylprednisolone. We were thinking that rituximab may not be the good choice for her, so we started her on tocilizumab. But despite on tocilizumab for about 1 month, she had further reduction in acuity. In fact, her left worsened to even hand movement, and there was optic atrophy. At this point, the MRI showed an improvement in the previously noted changes in the brain. However, there were changes which were worsening in the optic nerves, which is compatible with her presentation. So we treated her again with, as for a relapse, that's with IV methylprednisolone and 7 every other day cycles. And unfortunately, we didn't have a continuous supply of tocilizumab, so we returned back to her rituximab maintenance therapy, and she's currently on these treatment for long-term therapy. So the questions I have for the experts would be, could this be a case of relapsing MOGAD? We were intrigued by this neutrophilic CSF in her initial lumbar puncture. Is that a recognized occurrence with MOGAD? And how would you suggest to treat a MOGAD relapses or NMOS relapses during pregnancy? And do you have any further suggestions to improve the visual outcome of this patient?
Well, thank you very much. Very severe relapsing case. And as for the first question, so as you said, MOG IgG titer in the blood is low, and CSF has not been studied yet. But the first optic neuritis recovery is quite good, and followed by cerebral cortical encephalitis and so on. Even if the titer is low, this is probably the relapsing MOGAD case, probably. And as for the second question, neutrophil dominant pleocytosis in CSF is not rare in MOGAD. So I think it is compatible with diagnosis of MOGAD. And not many reports on the effect of pregnancy and delivery in MOGAD. But one study from France shows that unlike AQP4 positive NMOSD, in NMOSD, after delivery, especially during the first 3 months, risk of relapse increased significantly. But in MOGAD, at least in that French study, such a increase of the relapse postpartum was not seen, but there should be more data. So that the treatment of MOG relapses during pregnancy has not been established yet. But as for and also in MOGAD, in comparison with NMOSD, the therapeutic efficacy of rituximab maybe a bit less. Overall, it may reduce the risk of relapse, but probably the rituximab in MOGAD is most effective if it started very early, just after initial onset. But in this patient, it started much, much later. That may be why it did not work so well. But among the various treatments that have been tried in a limited number of cases with MOGAD, IVIG may be relatively effective. So that may be a choice in the future. But those are my comments.
Yeah, I would agree. This was also been my diagnostic impression. I have a question to you. When you see these patients, I mean, during pregnancy, would you use during the first trimester high-dose corticosteroids? Our obstetricians are very hesitant, and because the highest risk for damage to the fetus.
I don't think I have any personal experience on that. But I think if I'm correct, like we would use high dose if they come in a flare, like whether it be MS or NMOSD, we would still give high dose corticosteroids regardless of the trimester.
Also in Italy, we use it anyway. But about the visual outcome, I have to say that she's almost at floor because she's around 50 microns. So I'm not sure you can even use OCT to monitor future worsening, because it's difficult that future relapses will lead to further decrease. I'm not sure if you did a longitudinal tracking of the thickness, but I don't see many margins to improve visual outcome at this stage.
Thank you.
And the VPs were normal because there was recovery in the meantime of the latency. Thank you.
Great. Thank you very much.
We move on to the next case. Dr. Janya Jayawardena.
Thank you, sir. In the interest of time, I would like to proceed in a quick manner. So my patient is a 19-year-old who is awaiting university entrance with no past medical history, no significant family history, who was well until the December of 2022. She presented to a local hospital with unsteadiness, slurring of speech, and double vision, which was subacute in onset. There were no preceding infections or any systemic manifestations in the history or examination. In the basic workup done initially, there were no evidence of any inflammatory, infectious, or metabolic disorder, and the CSF analysis was also normal. This is the initial MRI brain of my patient. So there are T2 hyperintensities in bilateral striatocapsular regions, midbrain and pons. So this patient was treated as ADEM with IV methylprednisolone and then followed by oral prednisolone tapering. So the symptoms resolved and she was able to carry out her daily activities, but there was a persistent unsteadiness in the background. So following this, she got the first relapse in around 7 months after the first presentation, where she again presented with this cerebellar symptoms and double vision. And again, the basic evaluation was normal. There, she was tested for oligoclonal bands in the CSF and serum aquaporin 4 and MOG antibodies and ANA. All were negative. So here, the only drawback is the CSF oligoclonal bands were done with gel electrophoresis, and so it was negative. This patient again was pulsed with methylprednisolone, but this time there was poor response. However, these FLAIR images show that the same lesions are there. There is no increase in the lesion burden in the MRI brain. So this patient, roughly around 4 months later, had the second relapse. Again, she admitted with the same cerebellar symptoms. Then the subsequent MRI showed fairly larger lesions. And at this time, she was referred to the tertiary center, the National Hospital of Sri Lanka, for further care. At this point, induction was done with pulsing of prednisolone as well as with plasma exchange, and she was started on steroid-sparing agents, rituximab and MMF. So that was in November 2023. Following that, these are the images in 2024 March, where you can see basically the same lesion burden in both infra and supratentorial regions, pretty much the same. So these are the T1 images of the same patient. So again, so she was. This was the treatment that was given, and there was also a tiny demyelinating lesion. There were 2 tiny demyelinating lesions at C5, C6 levels of the spinal cord as well. So by this time, the disease was progressing in spite of immunotherapy. The disability was also persistent. So the CSF OCB, AQP4, MOGAD were negative, and she was given rituximab, the first dose in January and the second in February of 2024. She was also on MMF and prednisolone. She was then referred to the neurology unit. By this time, she was having a progressive neurological disease with MRI showing demyelination with lack of response to initial immunotherapy. However, her optic nerve pathway was intact. Her VEPs were normal. Symptomatically, she was not complaining of a visual impairment, and the cortical functions were also spared. So in the initial workup, the inflammatory markers, infectious etiology, malignancy screening, hereditary neurodegenerative screening, metabolic screening, vasculopathic screening, everything was negative. However, we wanted to redo the markers for CNS demyelination. So we repeated CSF and serum MOG antibodies as well as AQP4 antibodies via live cell-based assays. This time, again, they were negative. We repeated the CSF oligoclonal band, and it became positive. There were 4 to 10 bands of IgG showing intrathecal IgG production, and a diagnosis of secondary progressive MS was made. We started treatment with fingolimod, continued the treatment with rituximab, and put her on IV mitoxantrone as well. So this is the timeline that summarizes the events. So as you can see, her illness started in 2022 December, where she recovered partially with the initial induction with steroids, then relapsed 7 months later with incomplete recovery with steroid pulsing. The second relapse 4 months later with again partial response to plasma exchange, then given rituximab and mitoxantrone, and now she is showing some response. So currently the EDS is a 4.5. She's continuing with her education, but there is a background unsteadiness. There is minimal or no progression radiologically and no relapses currently since the last relapse in September. So the diagnostic questions are, is this multiple sclerosis? The MRI lesions, especially the supratentorial ones, are atypical of MS. And even with around 3 relapses, the lesions are confined to the same territory of the brain. However, the plus pointers are the CSF OCB is positive with good response to immunotherapy. And also, as you have noticed in the T1 images, there is minimal axonal degeneration. So is immunotherapy keeping the disease at bay? And the second question we want to ask is, how are we to proceed with the management of this patient?
Well, again, thank you very much for this interesting case. Some things are unusual if you embark on the diagnosis of MS, which I think is very reasonable. The very short period of the conversion to the secondary progressive stage, I mean, that's unusual. And then the complete normal VEPs I think are unusual, and the lack of new lesions on repeat MRI. It does occur, so I think it doesn't exclude it, but it's unusual. But I would, at the present time, with the lab data, not suspect anything different, and also given the severity, would have embarked on strong immunosuppression. Long term, I would switch to anti-CD20 monoclonals. There is the possibility, at least in Germany and some parts of Europe, to use siponimod because this is active SPMS, although I have personally not been very impressed by this in a case with as severe manifestation as this one. So these would be my comments. And we have long-term experience with mitoxantrone. It would be in the US on label, also in Germany. I don't know here, but to sort of keep the obviously severe immune aberrations at bay, at least for a couple of years, it's I think a very good treatment. But most of my colleagues probably would resort to anti-CD20.
Yeah, I agree with Professor Hartung that normal VPs you should expect them in about 20% of cases, not more, in cases of secondary progressive MS. And what's surprising me is the lack of clear progression between relapses. It's not that relevant. Most of the worsening seems related to the relapses that are strange not to have dissemination in space also. I mean, in time and space, because they're always in the same place. Yeah.
You described there that the lesions confined to same territory over the course of the disease. But after initial treatment, did you see the shrinkage or resolution of those lesions?
No.
No. That may be atypical for typical MS, and but since these patients did not improve based on the current treatment, although I myself do not have any personal experience, a few years ago, Professor Jill Idan came here, and he has much experience on mitoxantrone, and so I think that may be a choice as a next step. But otherwise, it's a very difficult case.
If I may suggest, somatosensory and motor evoked potentials in MS are delayed. So at least if they are delayed, you're not so specific, because also in other conditions they are delayed. But if they are not delayed, you can exclude MS at least.
Okay.
Thank
you, Janya. Let's move on to our last case, which will be presented by Dr. Nipuna Veerasinghe.
So good afternoon. The fourth case we have as the last case of the SLCTRIMS 2025. This is regarding a 40-year-old lady who presented to us with a relapsing remitting course of lower limb weakness. So basically she takes us back to 2015 when she had presented initially with this. Actually, these are taken from records. This part of the history was taken from the records and from the patient. So investigated for severe pain over the right thenar eminence. At this point, records indicated an ANA report had been positive with a high ESR, and that had been managed as a tenosynovitis. So 2 years later, after improving from that particular episode, she had left visual impairment, at which point she had undergone a visual evoked potential, which had showed delay with a normal MRI, and that had been managed as a retrobulbar optic neuritis, and she had been treated with IV methylprednisolone with recovery. And then in 2019, according to records, she had presented with a severe burning type of pain over the left upper limb and trunk. And MRI had showed short segment demyelination in the cervical cord, at which point a CSF OCB had been done, very negative. And that at that point, she had been treated with IV methylprednisolone for 5 days and cyclophosphamide as well. And she had recovered without residual disability. Mind you, these are again from records. This is not the presentation we got. In 2020, 1 year later, after recovering from that episode, 1 year back, she had come with bilateral feet numbness and bilateral lower limb heaviness. And neurophysiology had indicated mild generalized myositis with a CPK of 298 and again a high ESR. And at this point, again treated with steroids, cyclophosphamide, 2 doses given, and she had recovered. So this was the past history of this patient. And in January 2023, we got her with a 3-month history of bilateral lower limb asymmetrical weakness, which was progressive, associated with pain with no bladder bowel involvement. And at this point, examination revealed extensor plantar with hyperreflexia with a hemisensory loss up to T6 level. And MRI showed a long segment myelitis with a central lesion, which you can actually take it as a bright spotty lesion, which was extending from the cervical down to the cornus, which was a very extensive long segment myelitis. Further investigations revealed, interestingly, a low platelet, a platelet of 77, high ESR with a blood picture showing inflammation as well as thrombocytopenia. And causative investigations, TB screen was negative, CSF was normal. There are 5 polymorphs, otherwise normal. It was more or less a traumatic tap. HIV negative, serum calcium normal, ANA 1080 taken as positive, but 1080. And serostatus AQP4, which was negative, but this was actually done, the technique of investigation was ELISA. It was not a live cell based assay. And VEP was normal at this point. So, entertaining a possibility of a paraneoplastic also, she underwent a CCT chest abdomen pelvis, which revealed a simple ovarian cyst. Even though it was ORADS 2, she underwent ovarian cystectomy, malignancy was excluded. So she was managed with high-dose methylprednisolone followed by oral prednisone tapering, and she was started on mycophenolate mofetil as second-line therapy. And because there was no improvement for the initial intravenous methylprednisolone, she was started on plasma exchange. After 5 cycles, there was no improvement. So she was started on intravenous rituximab induction. Still, there was minimal improvement. Because of that, she was started on tocilizumab. Monthly 11 doses were given, 8 mg per kg. However, with tocilizumab, there was a very a gradual improvement of the lower limb weakness as well as the sensory symptoms. But unfortunately, because of the unavailability following 11 months of tocilizumab, it was we had to discontinue it, and she was sent for rehabilitation. So last year in October, while she was in rehabilitation, she was coming out of the weakness. Again, she started getting a lower limb weakness for about 3 weeks, which was progressing, and she was transferred back to us. Similar examination findings with another higher sensory level at T4 level. An examination revealed an atrophied cord, but there was a similar T2 high signal lesion, again extending from the cervical down to the cornus, and axials actually showed a possible bright spotty lesion. It was a central T2 high signal lesion. At this point, again, she was treated with intravenous methylprednisolone followed by prednisolone. The plasma exchange 5 cycles tried again. This time with plasma exchange, she started improving. The sensory symptoms improved. The weakness was slightly improving. And intravenous rituximab, she was started on. But because of difficulty in acquiring tocilizumab, we could not start her on that. But currently, she is on intravenous rituximab maintenance therapy, 6 monthly doses, as well as on oral prednisolone. And we are continuing the mycophenolate mofetil as well. So with this given history, given the possibility of autoimmune clustering, so autoimmune clustering in the sense, the ANA positivity, the past history of the myositis presentation, as well as high ESR, the thrombocytopenia in the middle of it. So we are wondering whether there is an AQP4 positive NMOST despite the antibody being negative. And then how long should we treat with immunotherapy, rituximab and or intravenous tocilizumab? Because as soon as the tocilizumab was stopped and then she was put on prednisolone tapering, she got a relapse. And then does she require surveillance for a malignancy in the long run? So those are the questions we have for the expert panel.
Well, thank you very much. one quick question is that relatively long spinal cord lesion ranging from cervical to lumbar cord, is that lesion really contiguous?
No, it was not a continuous lesion. It was initially, actually, the initial impression was it was sort of coalescing of short segment lesion. That was the initial impression. But then we went and discussed with them, and it was obvious, it was concluded that it was a long segment lesion.
Mm-hmm. So this patient developed optic neuritis and then relatively long spinal cord lesion, which is essentially localized in the central part of the cord. Yeah. And but AQP4 was not detected. So at this point, this case may be diagnosed with a seronegative NMOSD. And the very important pathological finding of AQP4 positive disease is it's a astrocytopathic disease. So if you can check the, well, hopefully CSF, GFAP, and if it's elevated, it could suggest astrocytopathic disease. Although in any disease that are destructive astrocytes, not just myelin and neuron astrocytes are also distracted. So elevation of GFAP does not necessarily mean that it's a true astrocytopathic disease like AQP4 positive NMOSD. But so those studies are important to know which types of cells are mainly damaged. So, I think this is very important case. And as for treatment, as I mentioned yesterday, as long as we make a diagnosis of seronegative NMOSD at this point, or rituximab, and then if it does not work, we may resort to IL-6 receptor monoclonal like tocilizumab. So I think this is a reasonable treatment strategy.
If you would like a comment, a neurophysiological comment, also the initial episodes with pain with upper and lower level suggest involvement of the gray matter more than the white matter, because otherwise you would have a level from a given level downwards. So it's more gray matter, which is not actually, which is more typical of NMOSD.
Thank you.
Thank you very much.
Thank you very much.
Right. Thank you very much, everybody. And before we wind up this year's Congress, we would like to show our appreciation to our foreign faculty, our guests who've been here throughout the Congress. And I would like to call upon first Professor Fujihara. Thank you very much, Kazuo, for being here once again. So,
Great session.
Professor Hartun. And Professor Leo Kani. So that brings this year's Congress to an end. So thank you very much for participating. I mean, it was a very exciting, very fruitful Congress. So I would like to thank all the participants and the faculty, of course, for being here throughout the 2 days. Thanks a lot.